Здравствуйте, уважаемые коллеги.
Hello,
Рада
dear
приветствовать
colleagues.
вас
We're
на
glad to welcome
международной
you at
конференции
the
по
international
изучению
conference
важных вопросов.
dedicated
И
to such important
сегодня
question.
лекции,
In
которая
particular, we'll be
касается коммуникации детей и
discussing
подростков с
communications
особыми
of
потребностями,
children and
информационные и
adolescents
развитие технологий.
with
Я
special
надеюсь, что сегодня нам удастся
needs
обсудить
and
очень
the
важные
technology of this
отдельные
communication.
моменты, которые есть
I hope we can
для
discuss important
современного современного
points of this communication
действия, которое позволяет нам
as
как раз
a
чувствовать
universal
уверенность
means
и
to
является важной такой
ensure
стратегией
a success
для
of the
достижения
communication, which is very important to achieve
личностной удовлетворенности наших
self-fulfillment
учащихся
of
детей и взрослых. Я хотела бы
children
представить,
and
меня
adults.
зовут
I
Ворошилова
wanted
Елена,
to introduce
я
myself. My
преподаватель
name is Elena
математики
Voroshilova. I am the
инженерии.
head of the Laboratory of Education Integrated Habilitation of Children with Speech Impediments
Также
in
представляю
Institute of
своего
Correctional Pedagogy.
администратора
And my co-moderator is
доктора
Margarita Rusecka.
директора
She is a PhD in pedagogy,
Государственного института русского
rector of the
языка
Pushkin
имени Александра
State Russian
Пушкина.
Language Institute.
Маргарита Николаевна, хотела бы
Margarita,
приветствовать.
uh,
Спасибо,
I'll give you
уважаемая
the
Елена,
floor.
дорогие коллеги. Очень приятно
Hello,
сегодня
dear
вместе
colleagues. I'm
обсудить
very glad to
взгляды
work with you
ученых
today
теме
and
в
discuss
высшем
such
образовании,
key
в
problems in
перспективных
correctional
образованиях и
pedagogy
образовании.
and
Мы
modern
сегодня с вами
education.
научились
The
изучать
most,
за последние десятилетия, связанные именно с
the
коммуникацией.
main
Мы знаем,
transformation are
что
connected with
лаборатория, которую Маргарита
communication.
возглавляла
Laboratory which
и
I
руководила,
led
ей
for several
руководителем,
years,
таким ученым, и
and
мы знаем вообще
I used to
сегодня,
be an active
говорить
scientist.
эти слова, все знают
I
о
think
роли
I want to speak in
ограничений.
depth
Мне очень
about
приятно,
this.
что сейчас мы работаем
And
именно в
I'm
той
very glad
парадигме, которую
to
она
work in the
воплощала в
paradigm
трудах и в трудах своих учеников-последователей. Она
of
очень
this
четко говорила,
laboratory.
что логопед– это
I'm
специалист по коммуникации.
I
И
will
именно
quote
этим
the
коммуникационным
сcientists
вопросам,
from
которому
this
были
laboratory
посвящены диссертации, посвящены
about
научному последовательству,
logopedists
является
who are
и мне
the
кажется, положили
guarantees of communication.
продолжили, наверное, многие
And
традиции советские и положили
our
начало
work
новому подходу к рассмотрению этих нарушений. Я уверена, что сегодня наша
follows the
беседа
tradition of
позволит
Soviet
в том
pedagogy.
числе
And
продолжить и развивать
today
творческие мысли коллег
we'll
по
be
задаче решения.
working in
Хорошего дня и удачной
this
работы.
direction and develop
Спасибо
correctional
большое,
education
Маргарита
further. Thank
Николаевна.
you.
И,
Thank you,
уважаемые
Margarita.
коллеги,
Dear
я
colleagues,
хотела бы представить
I
первых
wanted to introduce our first speaker
выступающих.
or
Первый оратор
speakers
представлен двумя авторами. Айвазян
because
Екатерина
there are two
Владимировна,
authors of
педагогический
the
социальный
article.
психолог,
Ekaterina
сотрудник
Ayvazyan,
исследований в области
PhD in
психологии
psychology, senior researcher at the Laboratory of Integrated Early
образования.
Intervention Research in the Institute of Correctional Pedagogy, and her colleague
Кудрину Татьяну Петровну,
Kudrina
кандидат
Tatiana,
педагогических наук, также старший
PhD in education, senior researcher at the Laboratory of Integrated
лаборатории.
Early Intervention
Я
Research
представила
of
два
the same institute, and they will
представления
present
образования
their
психотерапевта и
paper
ведущей деятельности в области
about
обучения.
formation of
Татьяна
communication
Петровна.
as the first leading activity in ontogenesis of a blind child. The floor is yours.
Татьяна Петровна, включите звук, пожалуйста.
Anna Petrovna, please turn on the sound. Thank you. Thank you for this possibility. I'll upload my presentation now.
Замечательно. Добрый день, уважаемые коллеги.
Hello, dear
Позвольте
colleagues.
познакомить вас с частью
Today I wanted to
большого
talk on a
научного
small
проекта,
part of a
который
big scientific project which was developed
разрабатывается в лаборатории
in the
комплексного
laboratory
исследования
of
в области ранней
complex research
Института
in
коррекционной
early
педагогики Российской академии образования под
support
руководством
of
Елены Ивановны Розенковой. Проект
children with
охватывает
special needs
изучение развития
in the
адаптивного
laboratory of
развития
Rosenkova.
детей первых лет жизни
It is dedicated
синдрома
of
малоадекватных
development
детей группы
of
риска
children at the early stages. These
интеллектуальными
are
нарушениями
children
развития.
with Down syndrome and
Екатериной Борисовной.
physically challenged and
Спасибо Елене
intellectually
Борисовне за
challenged children.
предоставленную
We
возможность
want to
сегодня
thank the organizers for this possibility to present our paper on development of communication of blind children. To begin with, I wanted to make a thesis. When we are talking about the development of infants, we're talking about their psychological development. What is communication? How do we imagine communication between mother and a child? What is the picture we imagine? This is reciprocal happiness. This is an expression of love, of tenderness, with sights, with touch, with hugs. This is how communication works. It's emotional and natural. What can be more natural and more simple than communication? But let's not forget that it's an activity. It's the first human activity and the main activity of infants. It predicts the development of psychological processes in a child. It develops very fast.
Уже в 10 дней
At
жизни
the age of 10 days, a child begins to concentrate on a mother's face, then address her smiles, and then interchange with mother, with sights, and communicate with her. This is the complex of rebirth, reliving, which is the first complex in a child's life. The communication of this age has natural emotional character and indirect forms. You can see how fast the communication is built, and it is arbitrary. We know that children has an ability to communicate. This ability is spontaneous and natural. In a historical concept of personal development,
мы понимаем, что
we
ребенок не
know
родился
that a
подготовленным.
child
Ребенок
does
рождается
not
с рецепторной готовностью к
have
реагированию на информацию
the
окружающей
readiness to
среды.
communicate.
Спонтанно
It just
это
has
не появляется.
receptorical readiness to react to the information of the environment, and it is formed on the base on its experience. But how does relationship
Становление
build itself?
общения происходит в несколько этапов, и взрослый играет важную роль
First
на каждом
stage,
этапе. Мать, ухаживая за ребенком, регулярно присутствует
there
при
are
его воспитании.
different stages, and the first one
Мать, находится лицо матери,
is
находится
dictated by mother's actions.
от лица
While nourishing a child, mother is about 10 centimeters, 20 centimeters from the child's face. And this is the most appropriate distance for mother. As a consequence of this interaction, a child knows how to find her in the space, and mother becomes the most interesting object for a child. She is moving, she produces sounds, and that's why a child's interest is directed to their mother. At the same time, mother interacts with the child as and treats it as a personality. Child has certain feelings of its value, and this feeling is needed. A necessity to communicate appears, and it reacts to adults that address to a child.
начинает развиваться средства. Ребенок дает
That's why children produce means of communication. They react to smiles, vocalization of mother, and mother does know the sense behind these actions. So we can see that every step in the development of communication is depended on the communication of mother and the child.
Для изучения мы выбрали самую непростую
We
группу
have
детей с двумя
chosen the most difficult
недоношенность и слепота.
difficult group of children to study. These were blind children and early born children. There were 25 early born children of age from 3 to 14 months, which is 26 or to 33 weeks. They were hearing impaired. Our study of interaction of mothers and children have found out that mothers treat their children as they are not visually impaired. They are um, at 20, 30 centimeters from a child, and they do think that the sound of their voice makes them inaccessible. The sounds produced by mother are the main sounds in a child's life, but children with the hearing impaired children can't find their mothers in space, and they do not express orientation and space orientation activities at this age. Mother expresses their attention to children with movements, smiles, and touch. Blind children can't understand communicative sense under these actions, and they do not define mother as a communicative partner. The activity of finding mother in the space is not developed. If there is no necessity to find mother, the development of communicative skills stops. Mother cannot interact with the child fully because child does not express their emotions towards mother. There are no smiles, no cries. The signs of children are not evident, are not clear, and are not do not correspond to the expectation of a mother. Face expressions, frowns instead of smiles. They are not relaxed, delayed movements instead of fast reactions. They turn away from the mother instead of interacting with her. These are the expressions of their, but they are not ready to interact with the mother. These actions cannot build a relationship with the mother because mother cannot read them and find the sense of in them. Blindness prevents building emotional connections between the mother and the child and introducing a child into human culture. To develop communication, blind children need special conditions, special environment, and it must be formed artificially. What are the ways to form it? These are special communicative actions of an adult, which help mother to organize the environment and initiate communication and support the blind child to comfort it. So to help a child to find mother, mother must be always turned face towards the child so it can smell her and feel her warmth. It helps it to see mother in space and see her face. She must help the child to move legs and hands and touch mother, turn head towards mother. Mother must start communication addressing to a child. This address must be distinguished from the speech itself. So the child understands that the information is addressed to him. And mother must see that the child is ready to interact with her. That and continue talking if a child is ready. Mother must watch a child and read their signals. No hurry in this. There must be time for a child to react. There must be some pauses in the speech and the repetition of actions which provokes positive emotions in a child. Dialogues must be very emotional and expressive and full of feelings. In the development of emotional communication with a blind child, mother should use special means, and this is our pedagogical work. Mothers should be told this, how to form this relationship and how to build a need of communication in a child and make them more initiative, teach them how to build dialogue, communication, and form emotional communication as a main activity of an infant. Thank you for your attention and interest to my paper.
Большое спасибо, Татьяна,
Thank you,
такое содержательное
Tatiana,
выступление.
for this paper. It was
Знаете,
very
я хотела
interesting.
спросить,
I wanted to
вот на
ask
этом
you
фильме были показаны
about the families you showed.
исследования, они
Did the participants of the study
были ли они из Москвы или из других регионов?
come from Moscow or other regions of Russia?
Большое полномасштабное исследование,
Where
поэтому
was the study carried out?
немножко рассказать нашим
Can you tell more about it?
Организации, да. Спасибо за вопрос.
Thank you for your question, Елена.
Действительно, проект очень большой. И вот
Yes, the
это
project was very vast, and the part which was dedicated to the development of blind children and communication with blind children was carried out
в организационном плане.
in
Но на
the
самом
Institute of Correctional Pedagogy.
практически все москвичи. Почему? Потому что
Actually, the children came from Moscow because we treated children in their natural environment. We couldn't study other regions because of these reasons.
материала, работа с родителями
And
проходили
the study and work with the parents
для любого ребенка и
were
матери.
carried out in a natural environment for mothers and children. We know that home is a necessary
чувствовали
condition for mother and the child to feel themselves comfortable
ребенок формирует, у которого
and calm.
формируют у ребенка. Это вот такое главное условие
This is
было.
the main condition.
Спасибо большое. Очень
All right,
интересно.
thank you very much for your paper. Dear colleagues, we continue and I give the floor to our colleagues from Moscow State Pedagogical University. Lydia Belikova, Doctor of Medicine, Professor of the Department of Speech Therapy and at the Childhood Institute. And Yuliy Filatovy, Doctor of Pedagogical Sciences, Deputy Director for Research and International Affairs, Professor at the Department of Speech Therapy, Director of the Educational and Research Center of Interdisciplinary Research in the Institute of Childhood of the Moscow State Pedagogical University. They will tell us about speech dynamic stereotype in the context of consideration of basic psychophysiological mechanisms of speech. You're welcome.
Thank you, Elena. I am glad to welcome all my colleagues, participants of the conference, our first international conference, which is devoted to education of children with special needs in the modern world. And of course, I suppose that the aspect that I am going to discuss during our today's conference, that the aspect of communication is one of those baseline things that are very important for understanding the different categories of deviations in development. And I want to thank the organizers of today's event for giving us the opportunity to present the results of our research, which touch upon the research of speech of children. And I would like to focus on the part of the theoretical experimental study discussing some of the motor function act, that research that we conduct together with Lydia Belakova. The study is supported by the Russian state. We've introduced the theoretical basis about the speech dynamic stereotype. We look at it as a result of the base system. In today's speech, we're going to use a simple definition which we define more fully, but we understand it as a psychosensor-motor unit. Psych, since it's psychological; sense, because it's about the senses; and motor, because it's about movement. What do I understand under this terminology? For us, this is the shortest unit of speech that could define all the things that we want to encompass during this study. This allows us to create such a complex yet short psychosensor motor speech unit that allows us to speak about a specific speech module, be it sound, part of a word, and word. There is a psychophysiological idea of the fact that what is an act of excitement during speaking, actually. This is an answer or response to an external or internal stimuli. And we analyze this stereotype from a point of the functional system of the speech. And this allows us to understand how actually this stereotype is actually the basis for driving principle of the whole speech system in ontogenesis of a child. As you can see on the slide, we have an afferent synthesis of the system. I'd like to delineate few key ideas of this functional system. One of the postulates of the systemic analysis of anything living in nature is the presupposition that it is the result of an action which delineates the system as a whole. That is the composition and the amount of matter that actually enters the system. And as you can see on the slide, the key component of the whole system, what you need, is actually the acceptor of parameters, or actually the stimulus. This gives us a quality of referentation which will be very key and very important for actually receiving the result, which will be in line with the system in place. Only then the model will be fixated in memory. It is at the moment of consolidation in the memory of this action. These actions are always compared to other models of a cell. As you can see in the case of afferent synthesis, the summary of the stimulus is actually being introduced into the system, especially when we're talking about the psychosensor motor stereotype. This is how we get the result. The study of psychophysiological processes is an interdisciplinary research actually with a multitude of different methods in order to receive objective results. We have discussed many different components of the locomotor module, and today we're going to speak about the bioelectric of the articulus apparatus as the most demonstrative results of the motor function in children from 6 to 10 years old with the electromyography. That said, we've studied the different electrical parts of the whole system. We've estimated different qualitative and quantitative numbers. You can see them on the slide. I'm not going to actually, I will speak about them in the context of the results that we received. And right now, next slide, I would like to stop on the qualitative characteristics. So we did an EMG of the ribs. In children of 6 years old, it was primarily of one type, and in 10 years, it was more compact. So in the 6 years, you can see it was more loose, actually. In both age groups, the borders were actually quite clear. The maximum amplitude of the electrical charge was actually pretty the same, but the amount of it and the height of this maximum amplitude only tended to go down with age. Then we did the EMG of the circular muscle of the mouth. In children of 6 years old, this form was actually double-phased and less fusiform. And then in 10 years old, it was primarily fusiform, and actually the double-phased scopate form was way more rare. There was no chaotic form in the children of 10 years old. There was a clear pattern on this pattern. The borders of the electrical charges in children of 10 years old basically did not even coincide, but this was in the children of 6 years old. One of the more variable parameters was actually the maximum amplitude of the charge. In 6 years, the maximum amplitude was closer to the beginning of speech, and 10 years, it had a tendency to go towards the middle. of the actual act of speech. Next slide, we present a small sample of the EMG. First slide is 6 years old, and then it's 10 years old, when children were pronouncing the word nose in Russian. You can see that there was a bit more of the background activity. It was about 40 or 50 microvolts in children of 6 years old. When we take a look at 10 years old, the background activity did not go above 20 microvolts, and the movement of the scopate muscle had a very distinct form to it. Now, discussing the results. The movement realization of the speech act was different from the locomotor function, actually, not with the difference in the results of the action, but also the fact that this type of activity happens in the time of the same articulatory processes as well as phoneme, which are very different in their psychophysiological functions. The bioelectrical study that we've conducted in the comparatory age difference allows us to say that with age, there is a certain sustainability to the pattern of the movement of speech muscles. Then, when children age to the age of 10 years old, the movement of the breathing muscles starts to become more automated and standard. The results show us that actually the maturation of these muscles is actually at the same time, happens at the same time. The process of stabilization of the scopate muscle during the speech function actually happens a little bit slower than in the breathing muscles. The blast of activity becomes more sustainable, but not at all standardized at this moment. As exactly in the age from 6 to 10 years old is actually the period of formation of this strict and quite non-flexible pattern of the electrical activity. So that means that the speech therapy that is being conducted in children 6 to 10 years old of the articulatory activity of the speaking apparatus is quite important in these. This physiological data coincides with the data we have about the actual act of pronunciation. As a result of the psychosensomotor function, we can see the result of the functional system of speech. And in conclusion, I'd like to delineate the few factors. The data that we've collected during this research allows us to actually speak about the speech dynamic stereotype in ontogenesis. The heterochronic nature of these anatomic parts of the speaking apparatus. And this also tells us about the stereotypization of the electrical activity of the speech apparatus with individual manner of how a person speaks. And it also should be said that the basis that we've conducted of evidence in the context of ontogenesis allows us to speak at length about the ontogenesis of different disabilities that children may have, especially in this category of age. And actually, in conclusion, I would like to show our gratitude for the chance to speak today. I would like to ask the Russian state for their support of our research, part of which we've presented today. Thank you for your attention. Thank you, Yulia Filatova. Quite a fascinating speech. I would like to precise a few ideas. Speaking about pedagogical aid of this work, it's quite very important to find out how well the dynamics of the movement stereotypes actually change. Maybe how much can we speak about this in the context of pedagogical aid? Will there be any specific directions on this, or how will the ontogenesis change the way we look at these things, taking into account the age groups, the age stereotypes? Can we use that in the context of pedagogical aid? Maybe there's a more differentiated ideas about it. Maybe you haven't touched upon this. If you could, a few words about this. Thank you for your question. Actually, first of all, the comparatory age aspect is very important. I'd like to point out that before speaking about pathologies, it's very important to speak about the ontogenesis data, because they point us out to the idea that this is a prolongated maturation. First of all, there will be a delay of the development of this stereotype. Secondly, there will be a delay in the breathing components. And how are we going to discuss this? Well, first of all, we're going to point out the specifics of the impairments of the non-verbal breath and breathing, and then the verbal breathing in children with differing, for example, dysarthry, allelia, or stuttering. And this data, which precise the structure of the defect and different speech impediments, they are taken into account when we prepare the health-conserving speech therapies, which are used in helping our children. Of course, there's also an individual approach in nosology inside of the speech pathology. And this individual approach to every single child has a very important aspect to the routerization when we treat children. Because this is very important. It's actually key to understanding. I'd say that following Margarita Russetskaya, I would like to address myself to Galina Chirkina. I'll actually say that in one of her monographies, she said about some patterns to anomalies in development that you should take into account when speaking about the systemization of data, which can touch upon speech patterns and non-speech patterns in children with speech pathologies, just as Rosa Yelena did it. And we tried to use these ideas, this advice, by using modern methods. And we're using the evidence-based practice, which is an international actual idea. I don't really know what's in action. Thank you very much, Yulia. This is very interesting. You pointed out not only the age groups, but also the nosological groups. When we speak about children with different speech impediments, thank you very much. We're going to wait for more studies from you and different publications and articles. Dear colleagues, we're now going to continue. And I'm very glad to pass the word to Olga Koronevskaya, candidate of Pedagogical Sciences, Associate Professor at the Institute of Special Education and Psychology of the Moscow State Pedagogical University. She's going to speak about the peculiarities and main strategies of communicative development of children with severe disabilities, conducted on the example of studying communication of children without parental care, which is a quite pertinent topic. And please, Olga, to the word.
точнее, на практическое
Hello, dear colleagues. I'll be talking about my practical experience because the research I carried out and which I will talk about today was organized by specialists working with a child with special needs and disabilities and organizations which fight for better life for adolescents and children with the special needs. This research is a part of a paper of the Center of Correctional Pedagogy. And during the last several years, we estimated the communication and behavior and the quality of life of children living in care homes or orphanage. The institutions of this kind. What I wanted to say, there is a direct connection between the speech impediments and communicative disorders, which is the main problem defined by specialists. These impediments make harder for children to organize classes and other activities and create problems in acquiring skills and professional qualifications. What is the main problem of people with the speech impediments? If a person cannot express himself in an appropriate way, they do it in inappropriate way. They use the measures of communication, which reduce the possibility of cooperation, because cooperation is very important in communication. Sorry, can I show the slides? Can I demonstrate it myself? If you don't mind. Colleagues?
Ольга Викторовна, мы сделали на полный экран, поэтому вы просто
Olga, we're showing your presentation. We'll change the slides.
Да, тогда, собственно,
All right.
мне нужен а можно я все-таки свою, потому что я некоторые изменения внесла. Вот,
Can I show my version of the slides because I changed them a bit?
Тогда разрешите мне демонстрацию.
Okay. So allow me to show it, please.
Сейчас, одну секунду.
1 second.
На весь экран получается, да?
So you see it full screen.
Сейчас все хорошо.
Да, спасибо.
Yes, it's
Соответственно,
okay now.
отмечаются
So
определенные сложности, которые могут
we
быть преодолены
underline the problems which we can overcome if we support a person in their communicative efforts.
Соответственно, в исследовании вот
In
последнего
our
исследования,
research,
которое
our
рассказывала,
latest research
28 воспитанников, которые находятся в
was carried out
разных
with
учреждениях,
28
ой,
children
18 до
from
20 лет,
12
из
to 20
38
years,
воспитанников
from,
4
from
пользовались речью,
28
остальные, ну вот, как речью, как
people
основной
studied only for
остальные
use
использовали
speech as a main source of communication. Others use it less, at less degree.
Это тоже был один из критериев, на основании которого мы выбирали группу
The
проекта, которые будут участвовать.
social behavior disorders was another criterion of children who participated in the research. Our aim was the reduction of behavioral difficulties of children with severe disabilities. So let's pay attention to the trainings of scientific workers to diagnose communicative skills and estimate communicative skills, as well as teaching children to use them, to use communicative measures. Means. So, to fix diagnosis methods, we use a matrix of communication as a more complex instrument and a list of the most important skills of communication. And the research showed that regardless of the severity of disorders, as I said, intellectual disabilities were common for all children. In this case, 17 children could make choices, and in this, at the second diagram, you can see that 6 people could ask for objects, and this is a more complex skill. Most of the children could not require information, which you can see on the third diagram. Only 6 children could refuse something, and only 5 could ask for help, and only 4 could finish their activities. Also, we watched the day of children to understand their behavioral particularities. What did these reviews show? It showed that children from 12 to 20 sleep a lot, up to 12 hours. They do not have a lot of free time. They participate in the activities with a special needs expert. Then they spend time on eating, walking, and hygienic procedures. We need to understand that free time is the time spent in a group playing with toys, and it is very important to acquire social skills to spend quality free time. For most of children studied, you can see these ratings of most important and less important. Objects and activities for every child. So you can see that the most interesting activity was food. Then other children were interested in sensorial materials. For example, when a child takes off their shoes and starts to play with it, then they showed interest in toys and technical devices. Then magazines were not that interesting for children, and didactic materials did not attract children at all. These are, for example, puzzles and other intellectual toys. So we can see that children cannot occupy themselves in an appropriate way, and this lowers their quality of life. We carried out a training with all social workers for 4 days. And further, we carried out practical activities to solve practical problems and find out what progress we could make. What was important? When we acquired all the data, we developed an individual program for each child. They were based on directed supervision of specialists who did not work with children. Then we made a diagnosis of communicative skills of children, talked to all the specialists based on diagnostic materials, and made supplementary diagnosis with some of the children with special needs specialists. Also, we fixed some problems with with occupations of the child and found the activities which may interest them. The program we developed included each child had a separate file with aim with goals, from 4 to 8 goals for each child. So what was reflected in these programs? The goal, what do we want to get from a child, which skill it should develop. For example, a child likes to drink, but water is not always accessible. So the child must ask for it every time. Then the place of training, materials, specialists, additional notes, and the form of estimation for every specialist working with a child. The goals were divided into group goals, for example, to teach children to say hi and say goodbye. From my point of view, it's more important to teach children to ask before saying hello. This was made by reminding children to make certain acts. Also, individual goals were fixed, which were connected to the development of skills. For example, an ability to refuse, because when people cannot refuse, they start throwing objects or do other inappropriate things. So the specialists worked with 3 groups out of 4 on teaching them to refuse. Another goal was to make the quality of life of these children better, teach them to eat by themselves, maybe not in a very clean way, but still by themselves. This was the main goal of the training, or to distract themselves in their free time by other means than usual stimulation, and also to increase possibilities to study. And this experiment turned out to be pretty successful. There were boxes with different toys and materials brought to children, which were simple enough in a technical dimension, and children could interact with them because and occupy themselves this way. But the materials were simple enough to play even by the children with
Должны быть
of
доступные, интересные. Должны быть задачи, связанные с
greater
изучением
age.
полового
Our
воспитания, потому что это большая
goals
проблема для взрослеющих
must
людей,
be
что активное
connected
время. И в
to
организациях достаточно много
age
умеют с этим работать.
and the environment,
Задача общей занятости
and
технологиями,
also
потому что
the
можно при том, что в группах
teaching
развивается
how to
определенный
use
навык,
technology,
вместе.
as
Задержка
well as
задача поддержки и развития
support
собственных
and
интересов.
development of the
Важной
interests,
показалась задача
individual interests of
которая
children,
достаточно небольшая, если
and
сравнивать с нагрузкой
increasing physical activity of
этого
children
возраста или там человека этого возраста
for
с
different
определенными
ages,
проблемами, но проживающего в семье.
because this is very
Очень
important
часто
for children
бывает
with
потому что вот то, про что я уже говорила,
disabilities.
бросается в глаза, что воспитанники
They
практически
get
всего не
they
делают
do not get
самостоятельно.
enough physical activity,
Достаточно много
and
помогают
also
родителям,
involve children in social
нет.
activities which can be beneficial for society.
Разработанных
What
специальных
did we
программ,
do?
разработанных
We
пространств,
made
были
timetables,
реализованы
recommendations. We created special environments,
по ним данные, вносятся коррективы, то есть раз в неделю мы встречаемся
and
для того, чтобы вот эти
we
вот
also
данные
collected data on
делается помимо проекта.
the research
Центр лечебной педагогики проводит
to
систематические
make
встречи.
conclusions and
Каждую
analysis.
весны мы встречаемся с
We
представителями Центра содействия семейному
work
здоровью, различными представителями, которые используют
with
эти данные. Мы
different
вместе
representatives of
смотрим, как могут решаться некоторые задачи, как сделать так, чтобы, например, все сотрудники умели пользоваться
alternative and supplementary communications to teach them how to use
разрабатываются методические
other methods and
очень важным является
recommendations,
обеспечение базы наглядных материалов, потому
as
что
well as provide them with the base of
используют в образовательных организациях. Обучение сотрудников
body of evidence of the research and teach
то есть про то, например, вот была очень хорошая идея у коллег
the
тоже
workers
в процессе
of
обсуждения,
social spheres.
есть специальные пятиминутки, которые позволяют сотрудникам не
For example,
которые используются
we
общении с неговорящими ребятами. И,
carry
соответственно,
out
тематически интересные игры со
some trainings, some 5-minute trainings to teach them how to use special science to teach children. This is the work we're doing. Thank you very much.
Спасибо большое, Ольга Викторовна. Очень интересно. Вы знаете,
Thank you,
чрезвычайно важную
Olga.
тему вы
The
затронули.
paper was very interesting. This is
Скажите,
crucial
пожалуйста,
topic.
вы
And
с
I
какими
have a question.
учреждениями проводили эту
What
работу? Где
were
вы
the institutions you
это
cooperated with?
какой они отнесенности, если можно, к системе образования, к системе социальной защиты они
What
относятся?
was their connection to social security institutions? Yes, they were the institutions of social security in Moscow and Tula and other organizations.
Какие-то результаты
As I understand, you have carried out the study for some years,
жизни
and how much did
детей
the quality of life of children increase during this period of time, and at what degree
можно ли уже что-то там судить?
they became better in communication with adults and other children? Thank you for the question. I think that we make estimations based on subjective personal opinions because we talk to people who do communicate with hearing impaired or with children with speech impediments. I can speak only for the children I work with. They were taught to ask with showing at objects and also vocally, and these trainings increase their abilities to cooperate. It is very important. Also, I wanted to say that the positive dynamics is a two-way positive dynamics, because when children learn to express themselves express their feelings, they become more sensible to nonverbal signals. And this dynamics is positive not only because children become better in communicating, but also because experts study how to communicate with such children. We can see drastic changes, drastic positive changes in professional skills of workers. Thank you very much. Yes, you were talking about the estimations, and I can only agree. This is the question that must be developed to make the quality of life of children in care homes better. In the institution of correctional pedagogy, we do treat topics like this. We do work with children in care homes. And I hope we will make progress in this direction as well and train more pedagogues for children with special needs. We are moving further, and our colleague, I wanted to thank our colleague that he is here with us because it's early morning in Portugal. And I wanted to introduce our colleague, Isabel Amaral, a doctor of psychology, expert consultant at Perkins International School Academy. She is a specialist, a professor at a Polytechnic University in Portugal and head of the communication school from 2003 to 2011. She is a very experienced specialist, and I'm very glad that you are taking part in our conference today. The topic of Isabel continues the topic of Olga. She will be talking about children with complex disabilities and communication in language and everyday life. Isabel, you can start.
Thank you so much, Elena. Good morning. It is an enormous pleasure for me to be here. And it reminds me of the good times when we had a chance to work together in several different parts of Russia. And yeah, I still think that we have a long way to go when we think about working with children with severe disabilities and their communication needs. I'm going to try to share my okay, this is always the moment when I have a little bit of a problem, but that's not a big problem because there is something else showing. Okay, can you see my? Oh,
yes, okay, it's okay.
You were showing it from your own. Okay. And how can I move on from slide to slide, Elena? Because now I have.
You can tell just next slide.
Oh, okay, so let's go back to the beginning.
Skip.
Let's go back to the beginning then, please. Okay, so my talk today is mostly concerned with a special group of children who have very complex and severe disabilities. And these combinations are cognitive, sensory, motor, and health problems, which means that many of these children are not able to walk, not able to see, not able to hear properly sometimes, and not able to use speech as their main form of communication. And this is a combination of problems that sets a unique structure which needs to be addressed in a very particular way. And this is what I would like to talk about today. Can we go more forward, please? Next slide. Our main goal for these children is not that they learn some skills. It's that they have a good quality of life and emotional well-being. And this would be the ultimate goal. And that this should be achieved not by training them in using special skills isolated, but in doing that through an approach which considers activity as a whole approach for children. So we don't approach children through skills, we approach them through activities. And this because we want children to interact with environments. They cannot move, they cannot see. We need them to approach environments. We need them to be able to understand what is around them. And communication will be happening inside this involvement in a natural environment. Next, please. Next slide. Elena. Okay. Now, let me go back just a little bit, because in order to understand this, we need to understand that disability is not just a medical concept. And this has been described for many researchers nowadays. The core of this concept of disability, the one before, please. Can I go back to the slide before? I'll follow my own, wait. Okay. Elena? I'll take the slide before, please. No. Okay. I was just saying, let it be like this. Don't touch it again. When we look at disability, we have to understand that these children that we work with have medical issues, that's a fact, but also they have a severe limitation consequent to these disabilities that does not allow them to interact with the world, to interact with people in the world, and this significantly reduces their development abilities. And this is where I want to really focus my talk. Children with complex disabilities are isolated, and therefore they do not have access to life, to normal activities like any other child. Big family of 5 children, if I remember it correctly. And what we see here is his older brother taking him to do some boarding, something. interaction holistically, meaning that they facilitate children's involvement in activities more than just teaching decontextualized skills. So teachers help participation and involvement in real life situations, because we want our children to be involved in as many natural environments as possible. Next, please. So our approach to development is based on the Bronfenbrenner theory that says development is the result of interaction of a person with the physical environment and the people in the environment. And these interactions invite, permit, and inhibit sometimes engagement in more complex interactions. So we have the child, we have the environment, we have the partners in the environment, and it's this interaction, constant interactions, that supports development. Thanks, please. Can I have the next slide, please? Elena? Okay, thank you. So basically, if we look at activities in the environment, these activities invite and encourage child participation, but not all activities are good for children to participate. Some children do not like some activities. Some activities might not be age appropriate for some children. So we need to set up a program where activities throughout the day are meaningful, age appropriate, time appropriate, and sort of create in the child's mind an idea of what a day is like. Oh, first I get up and then I get dressed and then I eat and then I go to school. But this needs to be in the child's mind, not just in our mind. So we need to be careful, because not all experiences might have the same effect on children. So basically, okay, then, so I remember I told you, okay, interaction with environment and interaction with people. And these interactions with people can be shaped not just by the identity of the child, who the child is and what characteristics does the child have, but also by the reactivity of people in the environment or objects in the environment. So the development of these children is shaped by interactions. The way they approach a person, the way approaches the child really shapes the kind of interactions the child will have. Next, please. Well, when we look at teacher-child interactions, we understand that teachers are not naturally ready to work with children with this sort of characteristics. We see teachers being very good with early intervention, being very good with working with close interaction, using rhythm, using movement, using speech, because that's what they know. But at this very early level, we understand that teachers do not always react appropriately to children's behavior. They do a lot of things. They carry on their own ideas, but they don't often stop for time enough to read child's behaviors and understand what he might want to say. Next, please. Okay, now you have to click again. I think I separated it. So, teachers do not spontaneously develop communication skills to work with these children, which is normal, because 99% of the communication that goes between an adult and a child with severe disabilities that does not speak require a good training in early communication skills, require training in the ability to develop turn taking, like I do something, I wait for you, you do something, you wait for me. And this turn taking is the number one basis of communication for a child who cannot speak, understand speech, or understand the environment. Why? Because if a child is able to understand that another person can interact with him, we set up a structure, we set up a basis for an adult being able to approach this child and eventually bring a lot of information from the world for him to understand, and later on bring this child more and more into the world for him to understand what happens around. The thing is that I'm just going to finish the last one. Communication is not always seen as part of the life of children, meaning that there are lots of communication objectives in the teachers' plans usually, but do they think of communication as something that needs to be there all the time and not just while you're training communication? Okay, so this is one of the questions you need to think about. Moving now on to factors which may, yeah, we can go on, please, we can go on. Next slide, please. Yeah. We look at these children and we understand that on one side we have the physical factors that limit their interaction with the world and with people. And we all know what it is: hearing, vision, motor disability, brain damage, all these kinds of difficulties. But there is also a lot of social environmental factors which reduce significantly their ability to be more involved in their world. And we can quote parent-adult interactions. We can quote opportunities for experience. Many of these children stay in the same place during hours of the day. Sometimes they eat in the same place, they sleep in the same place. And this goes against the idea that development means getting more involved with more and more and more environments around. Many of the children don't have frequent exposition to communication and language opportunities in context. They don't have many people who come to them and who try to use basic means of communication to interact with them on the activities that they are being involved in. Many times we come to them and say, hello, how are you? We talk about the toy that they may have in their hands. We point to it, we manipulate it just to let the child know that we are a bit interested, but this does not take long. It takes 2 seconds, 3 seconds, 5 seconds, and then we move on. So in natural context, we see very little interactions between parents, teachers, peer with our children with severe disabilities. Next, please. How do we compensate for that? Of course, we know that compensation for hearing involves hearing aids, cochlear implants, sign language, more visual information. We know that for vision, compensation means hearing, means glasses, means amplifiers. Visual amplifiers means touch, means using more objects. These are compensations for physical factors. Then we have movement. And in a minute, I'm going to talk again about movement because this is such an important issue when we talk about children who do not move freely by themselves. But we can help it with wheelchairs, with assisted movement, and particularly with movement within the context, movement for a goal, movement to do things that you like. And of course, we also need to compensate for brain damage. Many of our children have difficulties with coordinating information, with processing information, with understanding what goes around them. And we can compensate for that by using simplified language, if the case is that they understand oral language, by repetition in context, by providing them with more time to organize their brains for an activity, by anticipating what is going to happen, by keeping the environment organized so that they can move and know what is around them and what can they look for, and also by generalizing opportunities, meaning that if they learn to do something in one context, it is of crucial importance that we help them learn to use this same skill in all the contexts where it is necessary. So like if you learn to wash your hands, you don't just wash your hands in one particular place in school. Washing hands means washing it when it is necessary and in different places. You don't always wash your hands in the same place. So the concept of washing hands that we want to develop is not linked just to one place. It is linked to the place. It's linked to the time. You always wash your hands before lunch, for instance. It's linked to having your hands dirty. And all this information contributes to the child developing a concept. We don't want our children just to have skills. We want them to have concepts. And for that, we need to train, if you want so, all these skills in a contextualized way, not in isolation. Next, please. Oh, this is what I was talking about. I want to really make an issue about movement, because if our children learn to move with or without assistance, this tells them an enormous amount of information about the world. But for this, we need to make movement purposeful. And that means that in each experience, we need to help the child move around to look for the materials that are necessary, that help them to move from the classroom to the playground, for instance, with an organized way so that they create a schema in their minds. Often enough, we see children being carried around. We pull their wheelchairs and we take them where we want. But in their brain, this is not clear. We don't tell them sometimes where they're going, and we don't tell them through which areas are they going to pass by. All of this helps children think. We don't want our children just to act. We want our children to be able to think, to anticipate what's going on, because this is cognitive development. And so, yes, an example about movement. This is Jose. And I'm not sure we can see the video. If I touch it again, if you touch it again, the video would start. This is the first time that José was given one wheelchair that he can move by himself. Until this particular day, he was always carried around with the wheelchair. Now, on this day, we were expecting him to be curious about the wheelchair, but we did not know how exactly he would react. Can you please click on the video and see if we can see it? Yeah. This is the very first time that he is experimenting this. He still does not know a lot. He knows how to move it, but he knows that there is something that he wants to reach. And he's still trying to do that. He does not do it all by himself. We help him a little bit. How to move the chair into the left side. He's happy about that. And then he starts. And then he goes where he wants to, because there was his father with a balloon that he wanted to touch. Okay, next slide, please. Okay. So when we compensate for social environmental factors, we have to be very precise about the sort of activities that we involve children with. We need to look at child's interests. We need to look at activities that provide for learning, where individual goals can be embedded. We look for activities which have functional skills that we can teach in many other situations, like I was telling you about washing hands. And we try to have activities that children understand, have a behavior before and the behavior afterwards, which means, I'll stick to the washing hands example, like the behavior before could be, oh, my hands are dirty, I need to go wash my hands, I wash my hands, oh, wonderful, now my hands are clean. But we have to do this process with the child so that he understands this again as a schema, not as an isolated skill. Next, please. Also, we need to manage these activities so that we make sure that the children get more and more involved in the whole activity. So we want children to be involved in meaningful context, in real life activities. We have to take them out of school most of the time. Or we have to take them out of the classroom and move them around the school to learn to know that there are different environments, different activities, different people with whom they can interact. And so we want to shape our interventions as enhancing, supporting, and optimizing participation outcomes, children more participation in real life activities. We don't want to limit our intervention as a set of training skills in an isolated setting like the classroom. No. Children learn to live, not just to act in a classroom. And there's a nice story about a child with visual impairments and motor disabilities and cognitive impairments also, who is actually the son of a colleague of ours who made a very, very important decision for life. She said, my child will be mostly with me That's how she says, and I'll tell you a little bit more about this, and going to regular schools. So what she means is this child goes to a regular school, but when he's not in regular school, he is involved in activities with the mother. The mother is a special education teacher. She's also a speech language pathologist. She has training in adaptive dancing, and she really does very nice work with music and dancing. And she goes all over the country to do training, and this kid is always with her. Not to show what he's doing, no, he's just participating, being part of the life of the mother and the father, who is a musician actually. And this is a very interesting example of someone who did not decide that the school would be the place for his child to learn. The school is also one environment where the child can learn, but it's not the only one. He has a lot of experience around the country and outside the country, where he just goes with the family because they really do a lot of work outside the country. And this is not often seen as the contribution of parents in the child's development and learning. We don't have much time to talk about families, but in fact, school in itself will not do enough. We need parents to be with us. We need parents to participate and select activities and create interesting and motivating activities for our children. Next, please. We also need effective communication partners. And this is a big issue. Because constructing communicative competence is not just done by someone who knows a lot about communication, teaches a child who does not know communication. That's not how it works. The person, the adult who is going to interact with a child with severe communication disabilities needs to learn first how to communicate non-verbally, and needs to know afterwards how to understand this child's needs and behaviors, how to properly respond to it, and how to enlarge opportunities for using communication. Because what happens in a communication interaction depends on both partners, does not depend on one person. And tell you the truth, I've been working in this field for many years. Each new child is a challenge. It's a different child with a different way to communicate that we need to analyze, that we need to understand, that we need to properly assess if we want to be able to respond. But we also know that talking with a child or communicating with a child needs to be supported by meaning. What do we want to tell this child? What are we going to talk about? What is in the environment that is worth discussing? Oh, we can talk about we miss something when we set up the table. We miss something if we're going to start a new activity in the classroom. Where are we going to get what we miss? Where are things? And each step of the activity can be used as a moment for interaction. And so this analysis of diets, I call diet the interaction between two people. And we don't have much research on this. We have some, I think I've done some, and but it's not enough. We need more research on interaction, not just on what the child does. We need research on what does each one of them and how do they inter-influence them. I know this creates difficulties for research because the number of variables increases, but we can do it more qualitative like. We can try to understand who influences whom and how can we better exchange information with these children based on the activities that they are doing. Next, please. Because we know that if communication is the result of effective interactions between two partners, we have one partner, which is the child who is not very able. He does not know much about to communicate, but we have another partner. And next slide, please. So if one partner has a communication problem, the other partner needs to compensate, meaning that this can be difficult at some point, meaning that he has to adapt a lot of things, that he has to understand the child's behavior, that he really has to learn how to communicate. But if we have a lack of communication in both partners, communication is not possible. If what I'm doing does not fit the child's needs and abilities, I am acting as a non-competent communication partner. And this is, I think, one of the big problems we face when we try to think about communication for our children. We want our children to have a voice, not a physical voice, but to influence the environment in some way. I don't know if you have a saying in Russia, we do, and many others do, saying like silence is golden. Next slide, please. I would say that silence is not golden. The silence of the people who cannot speak, who cannot express themselves, who cannot influence in some way the environment is never golden. Because we all need to communicate. We all need to connect with each other in as many ways as possible, with as many topics as possible. Because this is a human need, a human right. And also because this gives children power to influence the world that they are involved in. And giving children power to act, to tell us what they want, to tell us what they don't want, to tell us that they like this better than that, is, I think, the life of a professional working with these children. And thank you so very much. That's what I was planning on telling you. The rest is not interesting. Okay. Oh, no. You can close it. This is nothing. You can close it now, Elena. Something that was not used in the end. Not enough. Thank you.
Спасибо большое, Изабель. Очень интересное выступление.
Thank you very much, Isabel. It was a very fascinating speech. It was a great pleasure to listen to. And I believe that the specialists and the practitioners that work with children, they will take up the things that touch upon enlarging the social interactions of children by using the different methods that you've described. And that all of these things will be very practical. Thank you very much. And dear colleagues, I'd like to pass the word. Isabel spoke about the different methods and activities that we need to enlarge the environment of the children. I'd like to pass the word to Irina Konstantinova, who is going to speak about the involving and introducing children with severe developmental disabilities into the space of social communication and music classes. Irina, He's a PhD in psychology, head of the expert council of the Center for Curative Pedagogy. To you, the word, Irina.
Can you hear me? Good afternoon. Thank you for invitation to the conference. I was very glad to listen to your papers. You have already said a lot from what I actually wanted to say. So sorry if I repeat some things. There are a lot of important things that were already said. But I hope this will create a base for my presentation. Can I please open my slides? Thank you. Can you see my slides? I hope you can. I work in the Center of Correctional Pedagogy.
Ирина Сергеевна, если можно, сделайте на полный экран презентацию.
Сейчас попробую.
И либо техническая наша поддержка.
Ага, да, может быть проще через вашу техническую.
Can our technical support open your slides?
Да,
Yes,
спасибо
thank
большое.
you.
Я пробовала, у меня не вышло. Тогда, да, можно прямо сразу второй слайд. У нас
Can you please open the second slide? So we treat different children with mild difficulties in learning or severe cases. When we were just found that we treated children which were not accepted to kindergartens and schools. Now the situation has changed, and these children assist the schools and special clubs and activities. And nowadays, all children go to school. This is what the legal system says. And we can note that communication in schools, despite the efforts of specialists, is not very successful because children do not communicate with others, and they find themselves isolated and study individually and maybe assist just for an hour. And our main goal is to teach children to communicate with the environment, to abide to social norms, and build relationships and interact with others in a certain environment. To present our work, I wanted to first speak about the difficulties which the child confronts. Inadequacy in communication and other conflicts that may appear. So these are children with disabilities of autistic spectrum. These children cannot demonstrate adequate communication with others. And it is evident that this diagnosis doesn't explain anything in a way how to work with such children and overcome those difficulties. And as experience shows, not only autistic children have difficulties in communications and abiding norms, establishing a dialogue. If we treat emotional disorders, we can note that autistic children have different particularities. There are more than I enumerated on the slide, but these are the main ones for me, which I personally treat. Firstly, this is the absence of communication means. A child can have speech impediments because of autism and delays in speech development, because of LLE, because of ICP. As it was already said, for communication, there is a necessity of two partners. Children that cannot speak or cannot use other methods of communication cannot establish dialogue with specialists who actually are ready to receive communication and interact with their children. So this way, we have only one partner of communication and another partner with difficulties in communication. So the dialogue is unsuccessful. If we see this children environment, we can estimate that children cannot interact with non-speaking children because of lack of means. And this limits its possibilities. Also create limitations on games, on education. A lot of people with severe disorders sometimes can communicate and establish a dialogue, but they run out of energy very fast. This concerns not only autistic children. They have low energy level and psychological energy levels. They cannot concentrate for a long time and go on in a dialogue. So we have to find out how to help them to go on with the dialogue and increase their reaction. This can be explained by hyperactivity. Some children run around and force around but cannot respond to a question and just respond in 2 minutes after processing it in their heads. Communicators cannot interact at such level, and sometimes they treat these children as they do not speak. This way, children learn that they are not responded and they develop speech impediments. They have means of communication, but not at the rate that others are usually communicating. Sometimes children do not involve in a dialogue because they're not interested in it. This is the characteristic of autistic people, but sometimes, for example, children like dinosaurs and are ready to talk only about dinosaurs. They will sing, they will play, and talk only if the topic concerns dinosaurs. Sometimes some children who have possibilities to involve into a dialogue do not do this because they have negative experience of being in a kindergarten or in a hospital, for example, without mother or after hard operations. These children expect to be heard and they need a long-term period of adaptation up to 6 months. When a child understands that he won't be heard, he is ready to communicate. These problems
И, в общем-то, на групповых занятиях
prevent
сначала
children
групповые
from
занятия
interacting with others and adapt in
А,
environments.
Будьте добры, следующий слайд.
Can you please show the next slide?
Вы его уже один раз показывали, а теперь уже пора. Со стрелочкой, вот с одной стрелочкой направо. Да, спасибо. В Центре лечебной педагогики
In the center of curative pedagogy, as we
такая система,
treats
согласно
such
которой мы
children for a long
детей
time,
никогда не берем на
there
групповые
is a scheme
а сначала он проходит
when we do not
менее длительный путь индивидуальных занятий.
hold
Эти
group
индивидуальные занятия начинаются
activities with children
программы,
right away. We have a very
начинает ходить к нам на занятия один раз
tender
в неделю по
side
часу.
program.
Это с ребенком дошкольного
We
возраста игровые
work with
занятия.
children for an hour once a week if the child is
Это скорее будет не
small.
игра, скорее это будет
And
какая-то деятельность.
in adolescent age, we do not play with them, but
в общении с одним игровым терапевтом,
interact through some activities.
со специалистом в мастерской, мы начинаем увеличивать его индивидуальную программу.
After this,
Очень часто
we
вторым занятием в программе ребенка
make
становится именно музыкальное занятие.
we add hours to the
которое я
program,
провожу.
and sometimes we add musical classes, which
Мы ставим
I
задачу
usually
его сначала к общению
teach.
вот с одним, с
And
двумя
we try to
взрослыми,
adapt
и потом
children
переходим
to
поступательно
communication with one or two
в
adults
нашу группу
and
и
um,
поступлению
get
в группу, где
them
занимаются
ready
пределами ЦЛП, детский
for
сад,
group
коррекционно-ресурсный
classes
центр. И
and
разумеется, ребенок
kindergartens or
специалисты,
correctional
которые
centers.
работают с сверстниками,
For
учителями в школе.
older
Если
children,
ребенка
this
волнуют
is
проблемы
communication
взаимодействия,
in the
адаптации,
school
то
and
сначала мы
with the
предлагаем
other
не
educators.
стационарные занятия, а такие занятия на троих. Он
Sometimes
приходит на занятия,
we
приходите с
suggest
мамой, с которой, понятно, он уже адаптирован, уже какой-то контакт
classes
есть.
for three, for
Или если
example,
у
with the
него
child
будет
and
хороший
their
контакт
mother
с игровым терапевтом,
to
с
establish contact
а с
with
музыкальным терапевтом ребенок еще не знаком,
special needs
ребенок может работать
specialists.
со своим психологом, педагогом.
Sometimes
Ему
we
создается
work
какая-то
with
обратная
psychologists
среда, есть
or
обратно знакомый человек.
tutors to create
Педагог принесет какие-нибудь песенки, которые он уже попробовал попеть с
comfort
ребенком,
environment.
понравилось.
Sometimes
Мы
we bring
создаем много
songs
разных
to
работ,
sing with
знакомых,
children and
очень привычное для
create
безопасное.
basis
И вот в этой
of
ситуации
comfort environment. In these
терапевт
situations,
предлагает что-то новое,
musical
интересное, знакомое мама и ребенок.
therapists
Ситуация
who
музыкального
introduce
терапевта
new activities
становится безопасной, предсказуемой
become
и
a zone of
совершенно
comfort.
доступной ребенку. Можем уже
And
отпустить маму, отпустить этого
this way,
немузыкального
children
терапевта и
can
перейти к индивидуальным занятиям.
work by themselves without
Мы
their
можем
mothers
с ребенком,
individually.
иногда больше себе позволить. У
Sometimes
терапевта уже не стоит задача распределять внимание между двумя.
children are more
Может всего себя
energetic and
ребенку. Иногда
an
после
expert can dedicate themselves to the child fully.
где много детей, ну что значит
Children
много,
are
5,
transferred to
7,
group
в общем-то,
classes.
одну группу мы не берем, и на музыкальное занятие,
We have groups
как
up to
правило,
7
мы
people,
ставим
usually
всех.
5,
Очень
7
сложно и терапевту
people, maximum 8, because it is harder for therapists to work with more children and pay attention to everyone.
Иногда идем через ситуацию мини-группы, когда ребенок начинает
Sometimes we work in mini groups when
знакомым или с новым ребенком ходить на музыкальное занятие, а потом они вместе идут на
children
групповые
start
занятия.
taking classes with their friends
С точки зрения адаптации,
or
обучения
acquaintances.
то вот
If we treat such situations, this is the way
и расширением
of
ближайшего развития ребенка.
gradual
Можно следующий слайд?
maturity of a
Спасибо большое.
child.
Очень многими специалистами и родителями
A lot of experts
разделяется
and
мнение,
parents
что
share
именно
an opinion
музыкальное
that
занятие
musical
является
classes
наиболее подходящим для
are the
выстроения
most
контактов, для
suitable
вступления во
classes
взаимодействие.
for establishing
Я, честно
contacts
говоря, не
and
могу
interaction.
выделить
I,
почему музыкальное занятие лучше
to be honest,
занятия
cannot
физкультуры
say
или
why
чем
musical classes are
групповые
better than
занятия, которые как
PE
раз
or
лучше всего
any other
подходят
activities,
ребенку.
but
Мастерской,
there are
понятное дело,
children
материал,
which involve in a dialogue better in
любимым делом.
a workshop or through other activities. But yes, there are children that like music more, and it allows them to pay attention to their partners for communication and establish dialogue. If we treat musical interaction as an involvement to more complex interaction, I can talk about certain characteristics that such classes that help to resolve the problems of communication. Each of the points is a scale of possibilities. Music can be very emotional. We sing sad or happy songs, and it is important for certain children to express their emotions, to feel their emotions, and recognize them. Some children find it impossible to express their emotions and they suppress them up to the minimal level.
И если мы немножечко перестараемся, ребенок уже у нас во взаимодействии истощился, музыкальное занятие позволяет
So
действовать
musical classes
можно очень
allow
радостно, а потом очень-очень грустная
to
песня, как все плачут.
act in different ways. We can express sad emotions or happy
И можно для
emotions
каждого ребенка подобрать вот
and
тот уровень,
build a program
то
for
проявление эмоциональной
each
насыщенности,
child
которое ему доступно
to
и
help
которое
them
необходимо.
express
На
accessible
музыке очень много разных
emotions.
деятельностей,
There are different
и это
activities
позволяет
based on
ребенка с
musical classes. This
нарушениями
allows
подобрать то, во что
children
ему
with
можно включить, что ему
severe
интересно.
disorders to
Выделяются,
find
определенные
the most suitable
первые
activity
деятельности.
for them.
Принято считать, что на музыке можно
So
петь, двигаться под музыку, играть на
uh,
инструменте.
we consider that we can sing,
Если мы возьмем тяжелого
write,
ребенка, который
or
владеет речью,
music
не
or play
владеет
an
мышцами,
instrument.
не
But if we
распределяет
take
энергию,
children with disorders who
инструментов,
cannot
он двигать
play
может
any
итальянский гимн,
instrument
который звучит как
or
ветер в поле,
can
если он не
only
танцует.
move
Музыка
in a
позволяет
wheelchair,
и такому вот ребенку с выраженными
even
ограничениями такой вид
such
музыки, который
children with
мы можем на таком
limitations
расстоянии
can
от него
be
положить
involved and
вещи в
introduced to
рукой, что
music.
вот он может все-таки руку каким-то образом протянуть,
They can play
использовать,
bells,
а
for
дальше уже
example, and
можно
produce
будет
sounds. And
использовать
after,
чтобы это было
or for
гармонично,
example,
и получался
musical
эффективный результат.
therapists find
Крайне редко у нас занятия
melodies
проводятся
that can be
абсолютно
suitable
пассивно.
for
Я ребенку пою, он вот это
such
улыбнулся,
children.
где-то отвернулся, и все. Все-таки хочется какой-то большей активности от ребенка получить.
We try to get more,
На
to get
музыке
children more active
сложно практически не
at the
общаться с
classes.
ребенком при помощи речи, потому что музыка
We
сама подсказывает, от чего я от ребенка хочу.
can
Музыка поактивнее,
use
он побежит
less
побыстрее. Музыка
vocal
остановилась.
language
Очень многие
during the
дети
classes.
без какой бы то ни было
Sometimes children, without any instruction,
останавливаются, меняют характер движения, и это получается
change the way
выполнение
they move, the
невербовой
way
инструкции.
they
И
behave
ребенку
after
сразу
the music
в
stops.
режиме регуляции
This is
поведения
non-verbal
можно
communication
понять,
of children with
сделать шаг вперед. Можно
physical
позволить
conditions.
дождаться реакции ребенка или наоборот,
We
если
can
ребенок
wait for a reaction of
достаточно
the
быстро
child,
чтобы это все-таки был диалог.
dependent on the music we choose.
Можно следующий слайд?
Can you
понимаю,
please
пора
show
завершать.
another slide?
Пожалуйста.
I know I need
Это
to
будет
К
stop.
сожалению, у нас, да, YouTube
я
канал
помню. Вот,
обязывает.
да, там еще несколько. Ага, вот, спасибо. Если посмотреть, опять же,
So
про
if we
ребенка, понятно, мы не вылечим ему ни аутизм, ни тяжелые ДЦП, ни умственная отсталость, интеллектуальные
if we
нарушения.
observe
Тем не менее, каких результатов
cases
можно
of
достичь на музыкальном занятии?
severely challenged children,
Снижается тревога,
either physically or intellectually, we can see the reduction in anxiety or openness for dialogue
и это позволяет
and
установить
better contact with
которым он
experts
хочет познакомить
thanks to
музыкальным
musical classes.
более выносливым. Мы находим такие
Children
способы
become more
тонизировать его, которые он может
energetic,
с собой
more
в любую
active,
ситуацию.
and
Можно, поскольку
this is the experience they can carry through their life.
диалог, мы можем понять, а что же ему
Children
больше
that
хочется.
have
Может быть,
established
просто
dialogue show
вот
their
мы
interests.
выяснили, ну надо же,
We can see
вот что-то звенит, что-то сверкает.
which sounds or
Очень интересно,
objects they like,
на другие занятия.
and we can learn what interests can be included in other activities. Singing and speech development is also promoted by musical classes. These classes help to introduce children to more complex environments and help them to interact with experts and peers. This is not a real dialogue. They will not joke in the kindergarten with their peers, but this is still a progress. Thank you for your attention. That's all for me. Thank you, Irina. It was very interesting to listen to your paper. I really like the reports which are presented today, but unfortunately we have very little time. So I give the floor to our colleagues, our friends from France. Paris.
Национального института обучения и
To
исследований
Cedric Moreau.
молодых инвалидов и адаптивного преподавания совместно с Хохловой Алиной Юрьевной, кандидатом педагогических
Who will present
сотрудником лаборатории образования и комплексной
his
абилитации
paper with Khokhlova Alina,
множественными нарушениями развития Института коррекционной педагогики, расскажут
the
нам
Institution of Correctional Pedagogy.
ребенка с точки зрения
And
теории.
they will
Дорогие коллеги,
talk
повторяю,
about
большая просьба, да, вот
the
тоже не
analysis
к сожалению.
of communication of a deafblind child from a disaster theory perspective.
Нас слышно сейчас?
Thank you. Can you hear us?
Хорошо не видно, но слышно.
We can see you, but we do hear you.
Но я думаю, мы можем начинать. И
I think we
попробуем
can start now.
Нас,
Вот, прекрасно.
хорошо, да.
Замечательно.
Очень странно. Нет,
Right,
не-
it's
не-
very strange.
Всё
Can you
громко
see
слышно?
us? Yeah, we can. Thank you.
Спасибо.
We can see and hear you. Hello, dear colleagues. As we were already introduced, I would not repeat everything, not to take a lot of time. We will try to be short. We will talk about
Я сразу прошу прощения,
in this way, Cedric will talk in French, and I will translate him into Russian.
как бы делать, да, на английском, это было сложно. Плюс еще концепты такие сложные, о
This is,
которых мы будем говорить, и разные
These are difficult complex that we will talk about. So I want to apologize for this like system, but we wanted to write most complex things on the slides to make them more accessible to everyone.
Общение слепоглухого ребенка с точки зрения теории катастроф.
Moi?
À toi.
Ok, good road, everybody. Je suis vraiment très heureux de participer à cette conférence et je remercie Alina pour la traduction.
Я рад очень, что приглашен участвовать в этой конференции и благодарю Алину за перевод.
Mais toi, bout de pain. Yes. Donc, nous allons.
I want to thank Alina for interpretation.
D'écrire le paradigme et puis après nous passerons avec un exemple concret.
Мы начнем с
We
объяснения
will start with the explanation of the paradigm, and after this we will show examples.
De souligner son isomorphisme. Car en effet, cette théorie postule un isomorphisme entre le monde perçu et le sujet qu'il perçoit.
Я начну немножко с пояснения гештальта, потому что
with
важно понять изоморфизм.
Gestalt theory, because we will talk about isomorphism theory.
Topologique et dynamique ne doit pas être évidemment pris au premier degré. C'est pas parce que l'on perçoit une sphère que la sphère va se former au sein de l'esprit.
И это динамическое,
So
топологическое.
this is a dynamic and topological definition which must be understood abstractly,
То есть не потому, что мы воспринимаем сферическую
not
форму, эта форма образует
because we perceive
сферическое
its spherical
Это также
form,
не строгое
the
кодирование
form
наших
is actually
ощущений,
spherical.
тех, которые
This
касаются
is based on our senses and orientation in space and feeling of the space.
Ok. Et donc, en fait, ce qui est intéressant, c'est que si les mathématiques sont utilisées comme support à la formulation conceptuelle de cet isomorphisme, il reste dépendant en fait de la structure biologique du contenant. Et cette transformation de forme n'est possible que, en fait, que par la nature identique des relations physiques susceptibles d'agir sur elles dans les deux espaces, à la fois l'espace du monde et celui de l'esprit. Et c'est ainsi que Köhler définit l'isomorphisme par quelque chose qui précise l'unité conceptuelle de ces différents champs de connaissances et qui assurait déjà en fait une toile de fond la notion d'organisation dynamique.
То есть даже если математика используется
So
в качестве
if mathematics is a base of a conceptual form of isomorphism, it is still an independent nature of a carrier. This transformation of a form is possible thanks to the identical nature of a physical relationship which can be present in spaces, in the world, and in the brain. This what makes isomorphism more understandable.
La théorie des catastrophes. Alors, catastrophe, faut l'entendre au sens de bouleversement, de changement.
Катастрофа это не обязательно
Catastrophe is not something disastrous. This it is at the first place a transformation.
Parce qu'en fait, une des grandes difficultés de la sémantique est que quand on veut analyser le sens, en fait, on le perçoit, mais on est aussi dans le sens. En fait, c'est pour ça que pour réussir à faire une analyse objective du sens, une analyse scientifique, il faut s'abstraire de ce dernier. Et c'est en cela que consiste en fait le grand intérêt de la géométrisation du sens.
И важным понятием теории
So,
катастроф, да, важным
one important notion in this theory, important mechanism, is geometrization of senses, because one of the difficulties with semantics is the fact that when we analyze some definition, we analyze what is inside this definition, the senses of it. But for geometrization, we need to look outside the box.
Et en
And
fait,
this
dans la
is the
mesure
approach to
où
the
rendant inerte
geometrization.
signification, on peut en fait les soumettre à une combinatoire qui échappe complètement aux catégories traditionnelles du sens. En fait, c'est précisément ce type d'analyse que permet la géométrisation associée. En fait, la géométrisation des process signifiants est extrêmement intéressante parce qu'elle permet de briser la circularité symétrique.
В той мере, в которой мы можем
At
геометризировать
the degree that we can geometrize the processes with senses to make them more inertive, to process them in non-traditional way. This is the analysis that allows for geometrization based on the theory of catastrophes. Geometrization brings senses and is very interesting because it breaks this semiotic chain.
Vise au contraire à réduire sa subjectivité, remplaçant en fait l'intuition sémantique avec son caractère subjectif immédiat par l'intuition géométrique qui spécialise son objet et la distance du sujet pensant.
Если чуть-чуть сократить, то
To be short, this way, what I wanted to say is that the theory of catastrophe is a theory where we evade senses and make them less subjective, replacing semantic intuition by a subjective character of geometrization.
Dans un espace à 4 dimensions, en fait, les 4 catastrophes élémentaires offrent à elles seules en fait la possibilité de prendre et de comprendre dans un processus dynamique la formation de n'importe quelle forme.
И согласно теории катастроф,
And
которая
according to the theory which is four-dimensional, which is combined from 3 dimensions, time of time, and 4 dimensions of elementary catastrophes, allows to see all the processes in the dynamic of catastrophes and their formulas.
Les 4 dimensions de l'espace-temps de notre réalité, il n'existe en fait que 7 catastrophes élémentaires topologiquement distinctes. Et en topologie, en fait, des formes qui peuvent apparaître comme très différentes sont en fait équivalentes par déformation continue. Et en clair, en fait, tout phénomène abstrait et observable peut être rendu intelligible par les effets de dynamique élémentaire et ce qu'on appelle les dynamiques catastrophiques.
И одна из основных теорем
One
теории
of the main theories says that for maximum
управляющих переменных параметров, это я о них уже сказала, то есть пространственно-временных
number of variables, which is 4, there are only 7 catastrophes that exist. They have different topological forms. These forms can seem different, but actually they're equivalent thanks to their continuous deformation. Every phenomenon observed
катастрофической, да,
can be the base for conclusions.
Qui a reçu la médaille Fields en 1958 pour cette théorie.
за теорию катастроф, ее
The disaster theory was developed by René Thom,
медаль Филдса в 1950.
and he was awarded for the Fields Medal in 1958.
C'est imaginer en fait que votre esprit, vous avez un isomorphisme en fait entre l'espace de votre pensée et l'espace sémantique.
Если, да, мы очень просто, да, постараемся обозначить
Explain this, to put this simply,
процессы, как бы, да, узнавания,
while talking about the processes of recognition and acquiring knowledge, we want to introduce 2 spaces. First, this is the things we need to learn, the knowledge we need to acquire. This is the space for reflection and also semantic space of senses.
Imaginez en fait que votre pensée c'est la boule rouge en fait qui va se déplacer au sein de cette typologie.
И мы можем себе представить, что
We
это
also can imagine
красный
this
мячик, который
red ball,
опускается в
which
семантическое
is being dipped into the semantic space.
La boule rouge, lorsqu'on comprend quelque chose, va tomber en fait au fond d'un trou, donc au fond d'une ce qu'on appelle une créode. Mais donc imaginez que donc à chaque fois que parfois, lorsque vous avez un obstacle à la compréhension, et ben vous avez justement une espèce de comment dire de paramètre seuil qu'il est nécessaire de franchir pour arriver à comprendre l'objet de pensée.
Ну, на самом деле, редко получается так, что знание прямо
But it's a rare case when the knowledge gets into our consciousness. There are some barriers which this knowledge need to overcome. It is the parameters of Barrow.
Ce qui est intéressant en fait, c'est qu'on peut les symboliser comme ça, c'est-à-dire que plus on comprend un concept, plus en fait on peut imaginer que le puits est profond et fin. Et au contraire, moins la compréhension est fine, plus le puits est large et peu profond.
И чем больше как бы, да, укрепляется знание,
The more
определенно
knowledge we have on some topic, more clear we have
вот, в нашем семантическом поле.
projection in the semantic
Notre
field.
compréhension passe de créode, enfin de bassin d'attraction en bassin d'attraction, avec systématiquement des paramètres à franchir et donc une énergie nécessaire pour franchir ces paramètres. Okay, we can pass from one side to another side with an energy. Ok, c'est pas grave. We don't have time. We don't lose time. Ok, donc en gros, ces formes-là à 4 dimensions, donc les trois dimensions de l'espace et celle du temps, peuvent se projeter sur des espaces sémantiques. Et donc maintenant, nous allons parler de la projection.
Есть проекции, да,
We have
в двумерном пространстве.
projections in a two-dimensional space,
Вот, и мы можем изобразить
which
разные
help
фразы,
us to
которые, вот, например,
illustrate different phrases. For
обозначаются
example,
понятием сложения,
the
и они
phrase made by addition,
выражают начало или конец
and
какого-то
they
существования. Ну вот,
in
например,
the beginning or end of
рассвет, да, и мы здесь, ну, утренний, да,
life. For example,
перевод здесь утренний рассвет, да, и мы видим, что это какой-то процесс, который имеет свое начало. Вот. И второе
the dawn begins.
Ok, donc, donc ici, par exemple, vous avez donc le pli, c'est le nom d'une catastrophe, avec le jour se lève ou le chat meurt. Vous avez une autre catastrophe qui est intéressante, c'est la fronce, où vous avez en fait deux objets, enfin un objet et un sujet, et en fait l'actant, le sujet S, capture spatialement l'objet O.
Есть еще такая форма, да, которая называется сборка, и вот это
There
интересно.
is another form called
И она
task,
показывает, да,
and we will talk about it in detail. It shows
субъектный октан, то есть, ну, октант это понятие, да,
this is a subjective octant which takes the space in these dimensions, and it is
Okay, donc, par exemple, ça peut se traduire en phrase canonique, Ève mange la pomme.
Например, мы можем
for
каноническую фразу
example, there's a
Voilà. Donc là, en fait,
Bible
c'est
phrase,
une projection à
Eva
droite,
eats an
on
apple.
ressemble à ça. Vous voyez, c'est comme si vous preniez une feuille et que vous la pliez de cette manière.
ну, вот эта вот геометрическая форма сборки.
This geometric form of cast has this form, like on the illustration, but another form of it was shown on the previous slide.
On va avancer, c'est pas grave. Voilà, et donc par exemple, ici, vous avez Jean lance la pierre.
Другой вариант.
Another variant, another example. Jean throws a stone.
Une autre catastrophe, c'est le papillon. Alors, il a choisi des noms un peu exotiques. Hein. Et donc, vous avez un récepteur, une source, et puis le message qui est transmis par la source.
Another form of catastrophe is a butterfly catastrophe. This is more exotic, and it is built from a message and the receiver of a message. The example is Eva gives apple to Adam.
Я еду из Парижа в Рим.
Et vous voyez, en fait, c'est aussi...
Another example, I go from Paris to Rome. The form doesn't change the sense. If we change the upper line or the lower line, the construction does not change.
Donc, vous avez aussi messager, alors, vous avez l'ombilique avec un objet, un sujet, un messager, un actant. Donc, voilà. En gros, ce qui se passe, c'est le messager s'approche de S, ensuite de S émane un autre actant, est transporté par le messager, et à l'approche de l'objet O, l'actant petit m se détache du messager. Ça va être compliqué.
Значит, здесь суть заключается в том, вот этой амбелической катастрофы, да, амбелической.
Another type of catastrophe is umbilic catastrophe. There is a topic transmitted through subjects, and they use some methods, some means to transmit this message. For example,
Да, и вот пример
Jacques
сразу.
goes from Paris to Strasbourg by train.
mais je vais peut-être accélérer puisque ça va pas être forcément très intéressant. D'autres catastrophes, comme par exemple l'ombilique.
Another catastrophe, another umbilic
Ça va pouvoir traduire
catastrophe
Да. Жан надевает
is called
Ça va
disaster of
être une
capture.
synthèse dans laquelle en fait, on utilise deux
Jeanne
instruments. Et donc classiquement, ça va
is on ahead.
de pouvoir traduire ce type d'action. Pierre attache sa chèvre à l'arbre.
Другой вариант называется катастрофа
One
синтеза.
more variant is catastrophe of synthesis. I won't talk about this in detail. There is a geometric example of a phrase. Peter ties his goats to a tree.
Еще есть форма, которая
Also,
называется
we have reflexive singularity form. For example, this is a refusal, pushing away something. This is the example of the catastrophe. And now we will proceed to our subject to show an example and explain it through these geometric forms of catastrophes.
Я расскажу сейчас немножко
I
про
will tell about the child we see in the picture. This is a blind and deaf child, fully blind and hearing impairment. From a far side of our country, who up to 9 years did not receive any semantic help and has never had classes with educators. He has healthy nervous system and brain, but he has some educational impairments, special educational needs. When we just met the child, she did not want to take objects into her hands and stimulated herself through aggression and self-aggression. She was all scratched, beaten, bruised, and parents put pampers on diapers on her hands to prevent her from scratching herself. And I took under my responsibility to take care of her and prevent her from hurting herself. And this is the example of introducing the outer world and subjects from the outer world. The child is scared of objects. She prefers adults to take them and interact with the objects. And while I was interacting with objects, she held my hands. So this is the video where I have to hold her hands to calm her down and prevent her from hurting herself, and picking her eyes with her. This is the explanation of this video. There are no evident reasons for such disorders, and we have no explanation for them. So we can proceed to the example. We have 5 minutes to show it. Okay, I see it. Fatima.
Да.
Yes. Super.
Слова говорить. Мгм. Да, пойдем выступать. Все, давай на связи. Ага, да, давай, пока, спасибо.
Bon, alors on va vous proposer en fait une approche méso, micro et macroscopique.
И мы вам можем предложить, так, там у кого-то еще включен звук. это не
Ничего
мы.
себе ты скачешь.
Да, мы вам
Ну,
предложим 3 варианта анализа.
So we suggest 3 variants of approaches. This is mesoscopic approach, muzzle, and microscopic approaches.
Il semble que l'enfant accepte dans un premier temps le peigne avant de le rejeter. Donc,
Здесь мы видим вариант сингулярности. Если
That's a singularity
подход, она отталкивает расчет.
when she is refusing to take an object.
ok.
Отказывается.
Okay, she refuses.
Ensuite, il va le récupérer.
Потом она ее забирает.
Then she takes it. This is the singularity of capture.
Donc en fait, après l'approche microscopique permet de regarder en fait plus en détail les interactions entre l'enfant et l'adulte. Et en fait, avant que l'enfant ne récupère le peigne, on note également que l'adulte en fait a transmis des vibrations à l'enfant par l'intermédiaire de ce peigne.
И здесь мы видим
Here we can see
катастрофу, да, где мы видим,
an
что ребенок
umbilic catastrophe where we can see that child takes a hairbrush after the adult shows the possibility to take it with her own hands.
Okay. Puis en fait, après l'enfant va récupérer et capturer la main de l'adulte.
Здесь мы переходим к микроскопическому, да, анализу. Мы смотрим, как
Then
ребенок
we
перезахватывает.
use microscopic approach to observe how a child catches the hand of an adult.
Puis ensuite, en fait, on est dans une catastrophe de synthèse en fait, dans laquelle l'enfant se sert de la main de l'adulte comme instrument pour utiliser le peigne afin d'atteindre son but qui est de recevoir les vibrations du peigne.
И сейчас
And now
En fait, une catastrophe de synthèse dans laquelle l'enfant va se sert de la main de l'adulte, il utilise la main de l'adulte, il use.
здесь мы видим, да, как
we see the catastrophe of synthesis when a child uses the adult's hand to sense the vibration.
Ensuite, l'adulte prend le contrôle pendant un court instant en fait pour peigner l'enfant.
после этого, да,
After this, the adult
хватает инициативу, чтобы показать, да, чтобы прочитать ребенка.
Et en fait, du point de vue de
gets the
l'enfant,
initiative in their hands.
И мы видим, что
And we can see
взрослый как бы
that the adult this way shows the gesture, the actions while hairbrushing.
Donc en fait, après, l'enfant se dessaisit ensuite de la main de l'adulte et du peigne. Donc on a deux catastrophes de rejet.
Тут мы видим сразу, что две катастрофы.
Here we can see two types of catastrophes. When a child refuses to take the hairbrush, and after this captures the hairbrush. And further we can see
перехватывает, да, снова берет расчет.
the child take the hairbrush again.
И он нам показывает понимание характеристик расчески.
He shows the understanding of the characteristics of the object.
Во-первых, да, эти свойства расчески, во-первых, это ее форма, да, вот с этими зубчиками.
Its form with
Да.
sharp edges and its purpose.
Lâche le peigne. Voilà, toujours la fronce, catastrophe de rejet.
Да, потом он снова показывает щепоть расчески.
Puis il le
He takes
récupère.
the hairbrush again.
Да, мы ускоряемся.
Et il utilise sa main pour diriger le peigne et se coiffer.
И после
And she
уже как бы использует, да, расческу
uses the hairbrush
с тем, чтобы
to
показать, что она будет ей причесывать, чтобы причесать.
show that she will brush her hair with it.
On peut résumer toutes ces interactions de cette
Вот,
manière.
и буквально нам еще нужна 1 минута для
And
того, чтобы
one more minute
все
to show the
происходящие
picture with
интеракции
all
между
the interactions happening. These are interactions between the adult, the child, and the hairbrush. We can see the first part of the video,
Просто все мы, которые уже изображали ранее,
the schemes which were presented earlier, but just combined together. And we can see the second part of the video.
Tout simplement, en fait, une catastrophe de don où l'adulte transmet à l'enfant les propriétés du peigne en lien avec la forme de l'objet qui est formé en fait par les dents et sa fonction, qui est celle de se coiffer.
Вот, а в макроподходе, да, в макроскопическом подходе мы видим просто
In the macroscopic approach, we can see the scenario when the adult gives the child the hairbrush.
Да, и вот что мне хотелось бы самой заключить, конечно,
And this is the butterfly catastrophe.
мне было очень
When I was getting ready to present this paper, it was pretty hard for me to get acquainted with the topic, and the practical work and theoretical analysis have shown me all the
полный график всех вот этих интеракций. Я была удивлена, что на второй половине графика
all the facts presented, and at the
на второй
second part of the scheme,
мы вообще не видим моих рук.
we don't see my hands, the hands of the adult. We can see that the child becomes more independent.
И потом идет вторая часть графика, да, где уже
We can see my hands on the first scheme, and then they disappear in the second scheme when the child
что происходит, да,
feels my support, but she acts independently by herself.
я не видела, насколько повышается даже в таком вот
I haven't realized how much
вот,
the independence of a child grows even in such small cases. So that's all we wanted to say. Thank you for your attention.
Собственно, все, спасибо большое.
Спасибо большое, Седрик, большое спасибо, Алина. Я надеюсь, что мы услышим все-таки продолжение, может быть, просто в рамках какого-то...
I hope
Here,
we'll
the
see the
continuation
continuation
of
of
other
this, for
institution.
example, in the context of pedagogy. We would like to finish this
This was very
fascinating
interesting.
paper that you've presented. Maybe we've seen this analysis from a different perspective, and it was a great pleasure again. We're going to wait for the continuation. I hope it will be soon, and we'll see you during our next presentations. Dear colleagues, sadly, we're very constrained in time. We're going to have another section, therefore, I'm going to pass the word to our next speaker. We're going to move to Belarus now. And right now, it is the ABCs for adults with intellectual disabilities living in psychoneurological care homes. It will be It will be Tatiana Lisovskaya who's going to speak, Doctor of Pedagogical Sciences, Professor, Department of Special Pedagogy at the Institute of Inclusive Education of the Maxim Tank Belarusian State Pedagogical University. Tatiana, thank you very much for finding the opportunity to take part in our conference. It's a great pleasure. We pass you the word. Colleagues, please turn on the slides of Tatiana. Good day, dear colleagues. Is the sound good? Yes. Perfect. Everything is heard, seen. Thank you very much for the chance to give my talk today. I'm going to keep it short. At least I'm going to try to keep it short. ABCs for adults. I'm going to basically give a few lines of text about that there was this project which saw the development and the drafting. It's of course, a collective of authors who've developed programs, handbooks, handbook recommendations, manuals for adults. I'm going to show you, this is the program for adults living in psychoneurological care homes. And these are the handbook recommendations that we have for specialists working with these people in psychoneurological care homes of our country. And you know, these are the manuals that we have. I'm going to show them. We're going to speak at length about this one, the blue one. Then we have also other books for adults, practical mathematics, for example, as you can see. This is from my colleague, Melina Gnestivitskaya, and so on and so forth. The thing is, we're somewhat used to the idea that the ideas of education, mainly when it comes to people with mental disabilities, is below the age of 18 years old. What's after that? To my great dismay, as I know in the Russian Federation or in the state of Belarus, after the care home, kids who have reached the age of 18 years old, they go to adult facilities, psychoneurological care homes. Here I quote that the potential for education is the ability of a human being to actually accept information. Could you please go to the next slide? I'll control it myself. I'd be actually going faster. Please, could you either control the slides? I need the next one. I skipped these and so forth. Yeah, this one. What do I understand as non-stopping education? What I understand as the system of the life of a person who realizes it's their right as a citizen for education. All of these things should be adjusted to the capabilities and the abilities of this person in question. The pertinence is then considered, of course, by the need of this person. What is the goal of this non-stopping education? Throughout the whole life of a person, it is education. Of course, in the context of interaction with other people who will provide the environment for adaptability and certain mimicry, you could say, and in order to improve the quality of life of this person. When it comes to the missions and the objectives of continuous education, a minute, please, while the slides are being rolled. The objectives of continuous education are formulated, and they are next is the development of tolerance when it comes to people with mental disabilities, the self-competence that should be fostered in these people, the understanding of their rights, their responsibilities, their abilities, and the environments that they have to realize themselves, fulfill themselves. All of this should be pointed at education that will be corrective correctional in nature in order to improve the quality of life of these people. It is also the reduction of the economic dispenses when it comes to the lives of these people, and the involvement of such persons in proper labor force when it comes to their ability, which will be within their abilities. This category of people, even though they aren't actually authorized to work and their full capabilities in when it comes to their rights in the country, it should be according to their abilities, within their capabilities. It should be also the support of social adaptation of this person with mental disabilities, the prevention of the non-regulatory behaviors that these people have. People who live in psychoneurological care homes, they exist in this closed-off socium that will limit their developmental possibilities greatly. They don't develop the sense of responsibility for their actions and acts, and as a result, even this leads to many problems. Due to this, sometimes people which are considered normal with slight developmental disabilities are actually confined to psychoneurological care homes. And many of those people who live in these facilities were actually deprived of education. For example, it is only since 2011 in Belarus there was this new disposition number 4855 about receiving proper specialized education in social protection institutions. Because before that, people with developmental disabilities did not actually have proper education and were considered not fit for actual labor. These people most often not cannot read, cannot count because they were never taught, or maybe they weren't taught systemically from time to time. And in order to re-establish the situation, it is very important to work to facilitate, to raise the quality of life and the level of education that these people receive in these psychoneurological care homes. This will allow to reduce government dependencies on this problem. We estimate the possibilities of these people, and we don't think that every person will be able to fully work, but most of these people, and even all of them, will have a chance to reestablish themselves as citizens and to work. And this relation, we thought that creating these educational conditions would be very important. It was an international project, creation of educational conditions for people with disability, for adults with disabilities in Republic of Belarus. And as I've already shown, we had handbook handbook recommendations and manuals for adults with disabilities. We train instructors, educators, and social workers who worked in these care homes. And we've conducted a major survey when it comes to adult people with mental disabilities. We've surveyed more than 50 people aged 18 to 52 years old. And more than a half, I think 62%, were people from the age of 26 years old to 40. They were quite equal in male, female, more than half have intellectual disabilities, be it slight, mild, or severe. Some have conduct misbehavior, some have other disabilities. More than 60% of them have lived for more than 10 years in different care homes. More than 20% of those surveyed couldn't actually answer the question about their age. Some of them could write their age themselves, but actually misplaced the figures, misplaced the numbers. Those who were of the age of 38, for example, wrote 83. The survey had 36 questions. Every person surveyed was asked individually. We explained everything as best as we could. But the question, whether do you want to study, 88% and 0.5% responded positively. Some of the questions, some of the answers actually were quite interesting. Some people put up an exclamation mark or a cross. Only 6% said, I don't know. And the most interesting answer is actually the question, why do you want to get an education? It was actually quite equal. 25% said that in order to be independent. 25% more said that they want to learn something. But the bigger part, 38.2%, said in order to go to work. 38.2. Also, we had answers like, I don't know. And there was one answer which was just, I'm afraid. What do you want to learn was the question that followed. And people said, I want an occupation. I want to learn to read. I want to write a letter to my mom. I want to learn to take care of myself, and so on and so forth. There was a whole slew of questions. And then some people, the question about whether you want to work, they actually had very sane ideas about their capabilities. They primarily said things, for example, I want to collect legumes, or I want to work in a garden. I want to drive around with manure. Or, for example, I want to work as a chef, just like my sister does. I want to work as a mailman. We had answers like this. So, the key group of respondents, stop on the slide, please. Yes. First of all, it was of working age, 26, 40 years old. They wanted to get an education in order to get an occupation. This has motivated us to create manuals for adults. I've showed you the ABCs for adults. Next slide, would you please? Of course, when concerning the contents, we've aimed to create a person that would be capable of living on their own. What does that mean? What does that mean? These are not academic manuals. This isn't classic teaching of reading or writing. This means that we want to create a person that is capable of taking care of themselves. It's a person that can live in a society. It is a person that is ready to work, to respect the regulatory norms in the society, to engage in social interactions. It is a person that understands the concepts of safe conduct. I'm just going to keep this presentation as it is because I don't really have the time to speak about the priorities. All of them are very, very important for our work because these books are going to continue to be published. We're going to make more. We're going to use these priorities. And I'm only going to speak about the grammar exercises that are in this book. the grammar education. I'm working with my colleague who's almost 90 years old, and this person is just fantastically grateful for having this ability to work. This is a manual for people who don't know their grammar, can't read, can't write, but these manuals give people with mental disabilities letters for them to learn thanks to the concept of symbolism and through itemization of these letters. For example, letter O, it gives you a few examples of similar symbols. For example, a chicken egg or glasses. The letter X, for example, scissors or the leg tables and the like. There are two books. We see the grand letters and the small letters. I'm going to open up this book. Yeah, as you can see here in my video. We give exercises with different situations. For example, a telephone conversation example. Hello, could you please ask Andre? Answer, Andre is not here right now. Maybe I should pass a message. No, thank you. Will be at home. He'll come in a couple of hours. I'll call him again. Please do. We have these situations here that are very easy to understand for people with mental disabilities. Well, I'm going to finish up now. Thank you very much for your attention. I think that there is a lot of work in this field to work with adults with intellectual disabilities. This is only the first step that we've done. And please do understand that life doesn't end at 18 years old. It only keeps going. And facilitating the educational process for these people, it is our goal to do that. Thank you very much. Tatiana, thank you very much. We hope to get a few examples of your books. As soon as the COVID regulations are off, you will see these books. And also, Happy New Year and good health to all of you. Indeed, we hope that next conference will be conducted in real life. So thank you very much, Tatiana, for the system. It is incredibly useful. I would like to receive it, as I've said. Colleagues were very time constrained. I'm going to pass the word to our colleagues from St. Petersburg, to Anna Lukina, candidate of Pedagogical Sciences, Associate Professor, Department of Pseudopedagogy from the Hudson State Pedagogical University, and to Olga Krusilnikova, Doctor of Pedagogical Sciences, Professor, Head of the Department of Pseudopedagogy. And their topic is pedagogical evaluation of the formation of communicative skills of young pupils with cochlear implants, studying at a school for the hearing impaired and the late deafened. Dear colleagues, to you the word, and please keep it short. The time constraints are very severe. I'm sorry, Elena. I think we're out of time, actually. There is Madame Voroshilova here. Colleagues, our section, we have been given 15 more minutes to actually finish up. And those who are currently connecting for the next session, I'm very sorry, but we're going to steal a little bit of time. Colleagues, please, to you the word. Good day, dear colleagues. We're happy to welcome you from St. Petersburg, from the Department of Pseudopedagogy. Thank you for the chance to actually give our presentation. I'm going to keep it as concise as possible. So please, colleagues, is it me who's going to launch the presentation, or is it? There it is. Is everything on screen? Yes, everything is well. Oh, great. So our paper concerns children with cochlear implants. Lately, there hasn't been much talk about students like this, and this is due to the fact that a deaf child with cochlear implants can actually perceive the smallest vibrations, so becomes basically non-hearing impaired. But it also says that the operation of cochlear implantation does not actually guarantee the child actually going to normal communication. This needs certain rehabilitation assisted by an educator. And sometimes operations aren't conducted properly or not completely or not very adequately. And there's a giant percentage of children with cochlear implants who find themselves in the school for the hearing impaired and the late deafened, because that's there. It's there that we can facilitate the proper environment for them, proper support that they need. In the research that we've conducted, we had children with CIs and hearing aids. I'm not going to speak at length about this because we're not very time-wise, but as you can see on the slide, that pupils from the School of St. Petersburg, from the School for the Hearing Impaired and Late Deafened, we had 80 children in total. We can see the communication before implantation of the experimental group with CIs was provided by different means. They used verbal speech. They couldn't use the full verbal speech in order to speak. And in total, the characteristics that we see here means that children with CIs were still deaf. We had 3 directions of study that we conducted here. We studied them in the process of speaking with each other and with adults, then with peers when conducting a mutual affair, and then when describing pictures. When we use the first direction, that means the CIs, when children spoke with each other, we received different results, quite varied results. And you can see an example on the slide. I'm not going to vocalize them, but these examples witness of the fact that the interaction between children with cochlear implants is not always actually responsory, since these children have difficulties in speaking with peers, with those of hearing impaired. They usually use sign languages. They often ask the educator to repeat themselves. They orient themselves on their peers. They do whatever they do. When it comes to pupils hearing impaired, this was pretty much better. Those who used hearing aid, they know how to use speech in communicating. When we used the second direction of our study, this research was conducted in the process of joint completion of certain tasks. Children had a few models of gloves, and they had to choose the ones that were same. Here we see that pupils with cochlear implants were quite varied, and with hearing aids we can see that it was practically the same from the first try. And the idea is that in analyzing their works, we noticed that children with implants couldn't really orient themselves on others. They didn't compete. They didn't try to see who was faster. They don't speak during activity. But those hard of hearing immediately understand what is needed from them. They try to orient themselves on each other. They conspire, they help each other. In studying the third direction of our study, in giving information based on a bunch of pictures, on a series of pictures, we've received similar data, whether it concerns the cochlear implant children or the hearing aid children. Both groups didn't completely form the ability to form their ideas in order to express them in verbal speech. But even here, the CI children are behind their peers with hearing aid. Here you can see the example of how the 4 years are actually trying to conduct and express their feelings. It's not the consecutive idea of pictures that shows problems, is the fact that they get lost in that, and they get lost in their ideas that they want to express, and they get lost in the structure, the morphological, of course, mistakes and the like. Given that, some of these children help themselves with gestures or other objects around. We've received similar results when it comes to these studies, and especially when it comes to read texts by the children. We asked children to read a text and then answer a few questions about the text that they've read. The answers were somewhat similar. The answers that were received that mean that not all the children understand what they've read. They don't really orient themselves in the text. They can't answer questions, not only of analytical character, but even when it comes to the contents of the text. In answering the questions, pupils try to choose phrases or words that sometimes mismatch with what they want to actually express. They make up words. It's not always they understand the question. It has to be repeated or paraphrased or changed, or even just write it out for them to understand the question. I'm going to skip to the conclusion of our work, of our research. This experiment allowed us to divide children into 3 groups when it comes to the level of communicational skills. As you can see on the slide, the percentages are quite varied. Of course, when it comes to those hard of hearing, it was actually quite interesting to us. The level of communicational skills is quite higher than in those with CIs. Such differentiation of children will allow us to give teachers a structure which they will have to follow in order to build a proper educational process in schools. The research witnesses of the fact that there is a weak grasp communicational skills in children with CIs, but there's also a positive tendency in creating these links, creating these relationships when it comes to smaller classes. But still, children with cochlear implants are quite behind those with hearing aid apparatuses. In order to improve the situation, we need 3 steps, and this is our 3 steps that we need to take into account. First of all, we have to organize the full-fledged rehabilitation for children after a cochlear implantation, which is an important and actually baseline part of this whole process. Then we need to meet the special needs of these children when it comes to education. That means that the educational process should be oriented on pupils with cochlear implants. And another need is the organization of regular communication of these children with those of their peers that are not hard of hearing. They need to understand their speech, the way they speak, in order to accumulate this experience and actually techniques to communicate with other people in the world. All of these problems can be facilitated thanks to proper organization, to enlarging the environment around the children when it comes to whom they are speaking to. And of course, it is the teacher who should also take part in this process. That is all. Thank you for your attention. I hope I made it on time.
Елена Леонидовна, вас не слышно, у вас микрофончик выключен.
Да, да, спасибо
Thank you very much, dear colleagues, for your speech. Thank you for being quite quick with all this. We have one more very quick paper to present. I give the word to our colleague, Elizaveta Baudet, researcher at the Laboratory of Educational Integrated Habilitation and Rehabilitation of Children with Hearing Impairments of the ICP-RAE of the city of Moscow. She'll continue this idea of children with cochlear implants, and her topic is communication and speech development in preschool children with cochlear implants. Please, Elizaveta, to you the word.
Good afternoon, dear colleagues. Can you see the slides? Yes, we can. The communication and speech development is an important stage of development in children, and particularly in children with hearing disorders. It provides children with an opportunity to perceive the world in new dimensions. Children, we will be talking about children with the fourth stage deafness. With time, they acquire hearing abilities, but they still cannot manage them. And that's why we carry out the rehabilitation work, which is aimed at the development of a hearing child. And this system was developed by Sataeva, and it allows children to proceed to rehabilitation and naturally evolve and develop speech. This is very important to initially develop emotional dialogue and make emotional interchanges more complex. During these interactions, children form speech, understanding of speech communication. The rehabilitation leads to natural hearing behavior, willing to initiate communication with verbal and non-verbal means, and provides children with cochlear implants with an opportunity to develop speech during real communication. We use every opportunity to develop children, and our goal is to change the way children with cochlear implants develop to natural ways, like hearing children. There are the reasons for carrying out the rehabilitations. First reason is the etiology of hearing impairment, which can be conditioned by many reasons. Then this is the absence of delays in development and the rehabilitation after operations. The development of speech can be divided into 3 groups. The first one in children which are close to their age group, whose hearing is close to the age group, and they can study in joint classes with other children. Another group where children have some hearing challenges and delays in verbal development, and they have some difficulties in communications with adults and peers. And the third group of children which with severe delays in hearing, and they can only imitate sounds and words. We do work with children with such conditions, and we can see progress in these groups in children who do not approach their age group norms. From the start of the rehabilitation up to school age, some children within 6 to 12 months after the first stage of rehabilitation has approached to the level of hearing peers in their speech and communicative development. They make up 53%. Other children needed more time to approach the age norm, and they acquired needed skills up to school age. They made up 25%. And some part of children did not overcome the difficulties. There were different reasons for this. This way, majority of people have achieved the equal speech development by the school age. From 43 children, 34 children have overcome the speech impediment, and their communicative behavior corresponded to the age norms. This is what I wanted to say. Thank you for your attention. Thank you, Elizaveta. Thank you for providing the time limit. I hope we can continue this topic in other papers. Dear colleagues, I wanted to thank everyone who have introduced their topics today. They were very comprehensive. I wanted to thank you for your research, and particularly, I want to thank our next section, which gave us the possibility to finish and listen to all of our papers. Thank you, dear colleagues. I wish you all the best. I wish you Happy New Year. Thank you, dear friends. And I think we can start the next section. Hello, dear colleagues. We are proceeding to another section. I am glad to welcome all the reporters and guests. We will be talking about rehabilitation of children with chronic diseases by educational means. For 2 hours, we will be talking about innovative foreign and Russian developments in rehabilitation of children at different stages of treatment. I wanted to introduce the moderators. This is Svetlana Lazarenko, me, and Natalia Pikалова. Hello, Natalia. Good afternoon. I want to remind you of the
российский психолог, педагог, дефектолог
anniversary of Lev Vygotsky, which happened the other day. We are glad to welcome Joaquim Cantina, the representative of Vygotsky Institute in Portugal. I also glad to welcome all the Russian speakers, and I want to give our present to Mikhail Derebin, who has the term of Vygotsky, which is special educational needs. He will be talking about special educational needs of children with the special health capabilities of children with special educational needs, clinical and psychological analysis and assistance. Can you hear me? I wanted to ask you to show my slides, and while we're watching my slides, I wanted to introduce the topic I'll be talking about and indicate my position as an amateur scientist defined by Gerson. I wanted to say that amateurs and amateurs in education and education for people with special educational needs, my experience in education allowed me to say.
Да, будьте добры, другой слайд, пожалуйста. Вот. И я имею в виду прежде всего ту позицию, когда иногда дилетант задает вопрос.
When I can ask questions which can seem evident to experts and specialists. These questions can open the problem from another side. And I wanted to indicate the approach I'll be using. This is the approach of public health. Other questions appeared during the reflections on the problem. Who are the children? Who are children with special educational needs? Who are children with special needs? What are their priorities? When do they care about their physical condition, and when do they care about their education? How does their physical condition influence education? I think it is evident that special educational needs of these children are connected to their physical condition. And I want to ask the question, if their health limitations limit their educational possibilities, this is my approach to the problem. I want to quote Article 23 from the UN Convention on the Rights of a Child. They define them as special educational needs. Do children with special educational needs have special educational needs, or they have the same educational needs as other children, but they need different conditions and different approaches to the organization of education? Let's take the term of special educational needs. It is pretty vague. We know that we need study, and study one more time. This is a famous phrase. At the moment, we can say that in the laws on education, it is fixed that it is directed on the satisfaction of needs of every person, needs of education during the whole life, at the subjects the person wants to acquire knowledge. And I do agree that this special education needs is a two-dimensional term. It may seem evident in the context. It does include the needs of children with a physical condition. But at the other side, these are usual needs of people who want to study. We can talk on the limitations caused by a health condition. This is the term of WHO. But we need to understand that this definition was thought in 1949, and the accent was made on the condition which must allow people to perform all labor, psychological, biological functions and allow for better quality of life. These positions, in a sense, make our approach holistic, because children with special educational needs in the educational system and a child with special educational needs and with special needs is still a child. It is the same child. Sorry for the technical problems. I wanted to remind our international speakers that we have an interpretation function which can be turned on your lower panel. You can turn the interpretation on after the connection of the speaker. I apologize, dear listeners. We need 1 minute to reconnect. Thank you.
Техническая служба сообщает, что пока у
Technical
нас
support informs that we cannot reconnect with Mikhail.
и если нас
And
слышит сейчас
if
Жоакин,
Joachim, do you hear
мы
us?
хотели бы предоставить слово
We wanted to give floor to the Portugal speaker.
It's okay. Good morning. Can I share my presentation?
Да, вы можете сделать это, нажав на кнопку демонстрации экрана.
Yes, you can do this. You can show it yourself, or we can ask our technical support.
Okay. Can you see? Yes. It's okay. Can you see my presentation now? Yes.
You can start, yeah.
Thank you very much. Good morning, colleagues and friends. I'm very happy to be here today. Thank you very much for the invitation for this so important conference. I begin to hear with a lot of attention the presentation of my colleague, because I think my presentation continue his idea. The topic is toward a new paradigm in development and mental health. This is my country. I invite you to visit if you didn't yet. And I want to ask, what do we say when we say education of children with special needs in modern world? If you, maybe, of course, you remember from 2 centuries, the famous 3 R's in education: read, arithmetics, and writing. And for so many years, this was the topic, and this is what the teachers and pedagogues concern when they speak about special education. And even in these times, I share here with you from the next year, next month, we start the new recommendations. And when we, in the international classification, we speak about development learning disorders, we continue with these 3 R's: reading, writing, and arithmetics. But this is as 200 years ago. So, but when we talk about education, we are talking about a mandatory topic for the development of a citizenship. So maybe read, writing, and arithmetics is not enough to talk about this. Everybody understands today that education is an important factor in the development of human being in order to arrive at consciousness, the liberty for act in life. It's very interesting because in several countries, including my country, Portugal, when we talk about special needs, we separate pedagogical department and health department. For pedagogical department, you continue to pay attention in read, writing, and arithmetics. And when some children has a different difficulty, as a different aspect that make these children or adolescent with special needs, for instance, is attention deficit hyperactivity disorder, oppositional disorder, anxiety, emotional, selective mutism, disorders of social function, in RESIS, these go to the Department of Health and not in the pedagogical department. But when we arrive to health department, we have a strong problem, as my colleague before start to share with us. Because when we arrive to health department, what can we find from the help from psychiatry? Diagnosis, pharmacology, diagnosis, pharmacology, diagnosis, and not more. Because psychiatry in these years continue to talk about molecular biology and chemistry. And after this, only classification. Today in psychiatry, we don't continue the tradition of psychology and psychopathology as the biggest professors we did have in the past as Zygarnik. Of course, I understand. I am psychologist and also I have medical studies at the Lisbon University. I understand how important is cellular and molecular medicine for these last 100 years. And if today medicine can help us so much, is because medicine is in the way of Virchow with cellular pathology. But is this correct also for psychiatry and mental health? What's about mental health? Is the same as bone health, heart health, etc. Or in the mental health, we should have a different paradigm, cellular or psychological systems, genoma or extracortical origin, as Vygotsky, Luria, Leontiev, Galperin teached to us in the past. I wish to share with you the important words of the biggest psychologist in the world, Lev Vygotsky, when he wrote the importance, in order to understand mental development and even mental health, it's important to leave the limits of the organism and go to the external conditions of life, in special relational life. Today, it was Vygotsky 100 years ago, but today, with the contribution of neurosciences, we have important support for the Vygotsky, Luria, Leontiev thesis. Today, it's very safe to say that only 25% of the brain is genetically engineered. And as Professor Leontiev wrote some years ago, the cortex of human brain, it has become an organ capable of forming functional organs. So when we go for this last year, for instance, or 2 decades, last 2 decades, the information, the data from neurosciences support very strongly the Vygotsky, Luria, Leontiev thesis and ask us to put our attention when we speak about mental development and even mental health to pay attention for these old and or maybe near psychologists. We have today a very strong support that push us to give up molecular and cellular understanding of mental development of children and adolescents and go to a cultural historical activity theory and maybe propose different interventions for these conditions of special needs as oppositional ADHD, hyperattention deficit, and etc. And also remember Luria when he said so many years ago in 1966 that in order to understand our topic, it's important to leave of the individual synapse or neuron because it it's totally unsuccessful. It's the molecular and the cellular theory from Virchow is very supportive for different areas of medicine, but not in mental health. So it's Virchow, molecular cellular medicine, that provide important support from pharmacology in different areas of medicine. Is it also supportive and useful for mental health? This is the question. Or cultural, historical, and activity theory, is it a new proposal in the field of development and mental health in order to give support for our children and adolescents with these special needs, not only arithmetical, writing, but also emotional and behavioral disorders. In our group for this list, 2 decades, we make a list as from the international classifications from different diagnoses, and we realized that some diagnoses, anxiety, obsessive compulsive disorders, depression, bipolar, schizophrenia, also autism spectrum, behavioral disorders, and dissocial attention deficit, etc., as a special different for another group, as congenital hypothyroidism, X-fragile, Prader-Willi, Engelmann, Down syndrome. What is the difference? In this group, we find different proteins for our children in different organs and systems. But in this group, we find different proteins only in the nervous central systems. And from the all knowledge in the biology and medicine, we realize that when a protein is in one organ, of course, it will be also in other organs. So why this group has only differences in the nervous system, and this group as in the different organs and systems? Maybe it can tell us, it is telling us that this group, the differences, are not from genome, are not an understanding from the cellular theory, but also, as Vygotsky, Luria, Leontiev touched us, different morphologies and the different functioning, because with an extracortical origin, it means social conditions of life, and it make different structures. So it pushes us to think different perspectives for these different children. And for this group, we decided some years ago to come back to Vygotsky, Luria, Leontiev, and as a proposal for Professor Zeigarnik for Moscow University some years ago, to cope with this diagnosis, not in the traditional psychiatric way, but in the psychological, historical, cultural theory. And of course, there are some children with special needs, X-fragile, Down syndrome, congenital hypothyroidism, that need at first medical intervention plus psychological intervention, but all this group also with difficulties in the development. And if we don't help them in order to provide their development, they will become as adults with problems. In this group, we provide first at all psychological intervention in the historical cultural support. Because we know today we have enough support from neurosciences to say that the morphology and the working brain depends more from external conditions than from genome. And as Vygotsky wrote so many years ago, the brain has enormous possibilities for the emergence of a new neuropsychological systems. So, of course, we have an opportunity to work with these children and adolescents and promote their development. But as Luria wrote, there is not better practice than a theory, and there is not a better theory than a practice. So let's continue with the clinical case. I share with you today a case of a young boy, 10 years old, with a diagnosis. When he arrived to our institute, Vygotsky Institute in Lisbon, he had already the classification of ODD, oppositional defiant disorder, with a very disturbed behavior, including at school. The director of the school have asked the parents to leave him from the school. Of course, to leave a 10 years old boy from the school with a very disturbed behavior, social behavior, as you understand, would be to condemn this boy from the future. His behavior is very disturbed at home and also at outside home. It means, for instance, at school, as I told you. But to say parents of a boy with 10 years old, your boy is very strange, is very difficult, please take it home, is not a response from the educational system. You can read in Lurian Journal, in the publication in this year, more complete details of this clinical case of this boy. So from the neurosciences, as I told before, we have enough information about the different morphology. But the question is this different morphology from a different genome, for a different DNA, as we can think in the other topics, specialties in medicine, or is these different morphologies only restricted in the central nervous system? It comes from different social conditions, orientation conditions, as Vygotsky, Luria, Leontiev told us, teached us 100 years ago, and very important, as neurosciences each year show us in the last 2 decades that these different morphologies can result not from genoma, but from different orientations, different social conditions. And if it's like this, so maybe as a psychologist and pedagogues, we can work with these children in order to promote their health development. This is the assessment of this boy, 10 years old. After the director of the school asked the parents to take him home, they come from Vygotsky Institute. We provided them neuropsychological assessment. It was in February last year, and we start to work with them in this proposal from Vygotsky, Luria, Leontiev. And this is the next assessment, and it was possible to produce a neuroeducative program and help is development. In a different assessment, Russia Exner is very used in our country, and you need to use it in order to official reports. And as you can see here also, all the development arrived with the intervention. Last topic, important.
И последняя тема, о которой мы сейчас поговорим.
Important, last topic. Pedagogical work with parents is very important. We have information and different publications that
есть огромное количество опубликованных исследований, которые говорят о том, что правильная подготовка родителей крайне важна и помогает снизить антисоциальное поведение. Но это не слишком простая работа. Как гласит, поэтому была найдена пошаговая теория Гальперина, которую можно использовать для работы с родителями. Здесь описано то, как педагоги могут взаимодействовать с родителями, чтобы придать им новые структуры и новые модели поведения при общении со своим ребенком.
To help parents to become more effective in their program education. This article will be published this month in this journal. It's a part, parent training program guided by Galperin theory of the development of human mental activity, a new effective approach when change becomes a real challenge for parents. And thanks to Galperin, we could design different programs for parents, for difficult parents. It means when we do 2 different series working with parents and nothing changed, so these parents move to Galperin parents training program with very effective results. About defiant or positive children, it's important to remind that this is the prevalence 5 to 10%. And without a very effective program in adults, it arrives delinquency, vandalism, or alcohol and drug abuse. So it's very important to take care of these children. This is also educational needs. The prevalence is increasing, and we can the traditional proposals as pharmacological in psychiatry, or even classical cognitive behavioral or psychoanalytic is not efficient in order to change, real change, when we do studies from long-term follow-up. But we are founding in the historical cultural, in the support of Vygotsky, Luria, Leontiev, and working with parents in Galperin theory, a very important support for our work. in our institute, we have about 400 cases that show us each year that cultural historical activity theory is more promising than medication and classical psychotherapy in the prognosis. And I finish my presentation with the words of the great Professor Luria. I want a psychology that can be applied to real people and the way they live in their lives, not abstract intellectualizations in the laboratory. Thank you very much for your attention.
Thank you very much for your presentation.
Позвольте мне поблагодарить Жоакима.
Please allow me to thank Joachim in our session. And now it's the next speaker, Alexander Wenger, Doctor of Psychological Sciences, Professor of the Department of Psychology at the University of Dubna, with the report, The Psychology of How Children with Disabilities Perceive Teacher Assessment. To you, the word, Alexander. Thank you very much. Good day, dear colleagues. I would like to tell you about the psychological syndrome of chronic unsuccessfulness, which is quite pertinent and quite widespread in people with special needs. Although not only they have this disability. Here on this scheme, this small model, you can see how this syndrome develops. Students during their educational activities have low results. This leads to low evaluation from the perspective of, for example, parents or teachers. It's not only from the perspective, whatever it is, the formalized school notes, school marks, but also the verbal marks or verbal remarks that parents usually use, and they often take the diminutive, like you're lazy or you're stupid. And this form greatly hurts the child. And these repetitive low marks and diminutive remarks lead to the fact that the child has a higher level of anxiety and has a reduced self-assessment. Now, the constant idea that the next mark will also be low has a very negative impact on the results that he has, on the results of this child, because this child is now distracted by the fact that he will, whatever he does, whatever she does, will have a low mark, a low note, and unsuccessful. Also, low self-esteem leads to the fact that often the child doesn't even try to solve any problems because this child is so sure that nothing will happen. And if you don't do anything, of course, nothing will change. So this leads to further low assessments from teachers, from parents, and so we have this vicious cycle. Or, as you'd like, they say in cybernetics, a positive feedback system. This starts in many different ways. For example, most often, this starts with a disease or a disability or a disorder. Even if it doesn't have any direct impact on the intellectual capabilities of a child, leads to, for example, to asthenia or other physical difficulties that the child might have. And this leads to low results, unsatisfactory results, unsatisfactory marks, anxiety, low self-esteem, and now the cycle goes again. The feedback is positive. And even if the child is in remission or is entirely cured of this disease, we still have the cycle in place, because the cycle will stay in place. exactly because of this. There is another reason for this, of course. There are the expectations of parents that are way too high for their child, that they are not within the abilities of the child. Sometimes this also happens due to the fact that parents expect more of the child, not take into account the special needs and special capabilities of their child. Even though the result, the estimation of a teacher might be actually normal, like B, for example, but because the parents expect more, this leads to diminutive remarks. For example, a child receives C's and B's. This is a normal, this is average. But the parents, from time to time, think that a C is just unsatisfactory, and even a B remark is unsatisfactory. Only A's and S's are what passes. Because of these diminutive remarks from this perspective of the parents leads to anxiety, low self-esteem, and now the results of the child start to drop off. And now the remarks are actually unsatisfactory, not C's and B's, but D's, F's, E's, and even it goes up to the point that when a C is a good thing. There's another reason of psychogenics. For example, due to some external reasons, external sources. For example, some disorders of family relations or disorders of how the child interacts with their peers, or a disease of one of the parents. This is sometimes very often seen because children react very acutely to a disease of a child. Or, for example, a child is worried about its own disease. And in this case, anxiety and low self-esteem are the entry point, you could say, of the psychogenics. But then we see the same vicious cycle. Because no matter the cause of anxiety or low self-esteem, anyway, this leads to low results, unsatisfactory ones. For example, the child's head is busy with something not connected to their studies, but to the fact that their mother is sick or they are sick. This leads to the same thing of unsatisfactory results. And even when the source of the psychogenics is removed, that doesn't mean that the cycle is over. Because here we see another, what I call in cybernetics, a positive feedback loop. And this needs to be broken from outside. In order to get over this problem, the psychological syndrome, which is quite widespread in children with special needs, but it's also quite common in children without any disabilities. You have to follow what Galina Peterman called as evaluation safety. This is what we have in our joint studies with her. We were taught to build our evaluation in this way, and we are sure that this is an efficient prevention method for this, and also helps to correct the cycle, for example, to remove it entirely. There are 3 rules to this. First of all, the key criteria for a mark or evaluation should be the preceding results of the child, and not any, for example, requirements of the curriculum. Those requirements are for the teacher. The standards and the norms, they are for the teacher. For example, if today the result of a child is at least a little bit better than the one of yesterday's, it should be noted. If you, as a teacher, cannot actually write a mark in any document or whatever, you should at least say to the child that they're doing very good. It's still an F, but there's a very good F. It's closer to a C, and then we'll go on to B's and A's. Then, next principle. In any task that a child performs, you can find something that was done well. And you should start with this point, this positive point. For example, a child was solving an arithmetic problem. That child needed to subtract, but he added properly. And you should start with this. Good job, your addition capabilities are fine. And then you should say, but let's actually what you were supposed to do. Maybe you had to subtract. Why is it so important? It's important because a young school child perceives the primary estimation, primary evaluation as an evaluation of this child. Because, for example, if you tell them you added well, the child will think that, oh, I am good, I'm doing good. If you start with the mistakes of a child, the initial evaluation will be, I am bad. Whatever is said after that will be post factum, will not be perceived by the child. So in order for the child to have a good self-esteem, you should start with the positives. Whatever it is, should be a positive. And now, last but not least, the negative evaluation can only be possible in a situation when a child has a grasp of the concept that they can use in order to, for example, not do analog mistakes. For example, if a child made a mistake in whatever it is in the curriculum, you should give the child a way to correct all of the other mistakes, which will be similar to this one, the primary one. And that's when you can actually give the child a negative remark. Or you tell the child the method to correcting mistakes, but don't give a negative remark. That said, it should be said that many adults think that think better, be more attentive is good advice. And this is not the method, because the child does not understand how to think better, how to be more attentive. You should give extensive, maybe even exhaustive pieces of advice for the child to correct further mistakes. This is actually everything. Thank you for your attention. Thank you very much, Alexander, for such a concise report. It is very important for the topic that we are actually discussing today. If you hear me, Mikhail is back. Yes, thank you very much. You are actually back. Everything is fine now.
All right, I'll try to be short. Finished on a child within the educational system. So we have questioned what are the bases for estimation of special needs? What are the procedures and what condition these physical challenges? Up to the recent times, public health had a classification of diseases of the 10th edition. And talking about this, I wanted to underline some positive and negative points of the subject we are talking about. For the first time, we had the notion of psychological disorders in the document of public health ministry. And it included some disorders which develop in early childhood. So When the Public Health Ministry issued a document on a psychological profile, its services treated all kinds of psychological and behavioral disorders. And from this point of view, methodologically and diagnostically, this deficit has played its role. I wanted to say this because it allowed us to create instruments to help children develop skills and qualifications. These limitations in the mental health field must be insight to SIGs in standardization and treatment of a certain population. So this is an important point. I wanted to underline that we are in need of diagnostic and estimative instruments. Secondly, I wanted to say that children are mainly supervised by clinical or hospital psychologists, which are not educated. It is not the competence of neurological service. There are 8 mental health disorders which must be treated by psychologists and psychiatrists, and clinical psychiatrists are these elements of the chain which still pays attention to these categories of patients. So I also wanted to talk about the change of paradigms connected to a new classification of 11th edition. And there are new definitions which seem important for me in the context of the topic we're talking about. There are no more definitions of diseases of early and adolescent age because they became more widespread and are noted in the structure of other disorders. This is how medicine revived the saying that a child is an independent unit and not a stage of a part of adult. These neurogenetic disorders make a subject of interest of correctional pedagogy and what Mesishev called medical pedagogy of psychologists and educators. This is the point connected to neurogenetic disorders. Is what we will work on in the perspective. In a good sense of this world, we will destigmatize the term of mental disorder and estimate rehabilitation potential of each child. We make accents on this innovative direction in public health, because old bases allowed us to create a multidimensional image of a child's health and its limitations. This is the British classification, first introduced in 1998, which was called the multi-axis diagnosis. And it allows to create a full image and ontogenesis of its intellectual and somatic development, which is connected with psychological conditions. And group Z, which is studied in, which is connected to social factors. And this multi-axis diagnosis has played very important role in complex medicine. In the international classification of diseases, modern medicine changes the paradigm. Instead of the paradigm of a disease to the estimation of dysfunctions connected to physical condition. So, at the moment, public health introduces new classifications. These are new instruments which do not seem standard instruments for public health. We do not estimate the reasons of this disorder, only psychological and somatic status of a person. We are talking about functioning, and when we're talking about special educational needs of a child, we need other terms.
Создаваемый на парадигме МКФ.
So I think that ICF
нашей проблеме, обсуждаемой проблеме,
will treat the problem we are discussing right now, the problem of physical condition, with new instruments. It is important to say that ISF is very important for modern medicine. It shows the potential of its instruments of diagnosis and connected to the quality and the need of quantitative representation of existing methods of diagnosis. We use this classification while estimating the state of the condition, and medical and social expertise make up individual rehabilitation programs in the frame of which we can carry out medical rehabilitation and psychological rehabilitation and social rehabilitation within the public health system. The adaptation of these instruments to serve the aims of special educational institutions can be
в котором уже
very real. And here you can see the site with enumeration of all instruments of estimation of psychological, emotional state of a child, and also classification of disorders. In connection to this, I wanted to say that the perspective for the future is to replace
когда вот ребенок с
dual holistic approach when a child with physical condition receives third assistant, third field where their problem is treated as a psychological field, and clinical psychology can help in this because it studies medical side of the problem and can address to medical specialists and the Ministry of Health. And at the same time, it solves the problems psychologists solve, even in the clinical field. These are the problems which were discussed at the latest conference with the president. It was suicide, aggression, illegal activities. These are the problems that must be solved. These are the problems of intervention, of clinical psychology into school educational psychology and rehabilitation of children with special needs. Thank you, Mikhail. Thank you for your attention. Thank you for your paper. Sorry for technical difficulties. And we continue. And we want
We're gonna ask Varlak Siri Harun, virtual reality.
She will be talking about virtual reality as a form of
escapism for adolescents and children with special needs.
Thank you very much, everyone. I'm very glad to be a part of the international conference, and thank you for inviting me to be here talking about the virtual reality as a form of escapism for teens and special needs for the children and patients as well. I'm from Bangkok, Thailand, from Silpakorn University. I think you guys can see my slide clear and my voice is clear. So it's going to take about 15 minutes to wrapping up all of this. What is VR? Actually, it's just not new terms anymore. It's referred to the technical based creation through multiple sensory channel and allow user to interact and with the simulated world and environment, which is already popular for entertaining and all kinds of the other treatment actually in the hospital as well. We compare about the VR, AR, and mixed reality right now because we have going to be more of the dimensions including into our device. Speaking of the virtual reality, it's just the place the user in another location entirely, and that location is the computer generated or captured by video and entire exclude of the user natural surrounding. And for augmented reality, the augmented reality is just you still there in the place that you are, but we use some other device, for example, Google Glass or the other application to help you simulate some the other, like objects, but on overlaid with the layer of digital contents, but you're still at the same place. For the mixed reality, it's more mixed between VR and AR. And yes, it's the objects are integrated into the responsive to the natural world. And the virtual world under that in the photo, like here, is going to be look more like it's already there with you. So it's make more real in the sense of, trying to make things more feels real for the people. How about the escapism? The Dr. Tatiana invited me to talk about this, that how it related to the children with the special needs. The in the terms of escapism in virtual reality, it describes as a condition of the people try to avoid or disregarding the real world situations, and usually refer to, like what that they decide to separate the actual world for the virtual world as well. Why we need to escape to all these kinds of technologies or the computers? Because a little get away from the reality might, like provide them some of the peak of the fresh of the experience in the virtual world. That's it. The people want to escape. And what can VR do to the users? The simulation that enable users to put their thoughts and views into the action into the virtual environment, and often the features even that are comparable to the real world situations. And the player might have the, experience different results than in the real life scenario. So they can be anything, they can do anything. So for example, like in the game called The Second Life, I used to fly from Bangkok to, like the Red Square in your country because I never been there. So I just want to see what it look like. And it's so surreal in the, like the virtual world, that is very special. And then escapism come into term that when you deep into something and you want to escape from something else, it make you more enjoyable. So escapism can be both positive and negative. Regarding individual uses, good escapism of VR help the individual to experience the different viewpoint which may not exist in the reality. Bad escapism freely refer to the harmful practice to avoiding the real world challenge or the difficulties in life, especially the teenagers. They want to, like deep dive into that. Escapisms in virtual reality, this is the, I would say, the device and the helmet that help their just experience in another world environment. Now there are so many fundings, advancing technologies by many companies are developing VR headset to help the human to leave the real world temporarily using VR. This means that the playing casual video game doesn't mean that you call them escapists. It's just playing some game. But if you plays on the long hours or the all days, every day is called escapism. So how about VR help the doctors and therapists? And there's many doctors here, real doctors. I'm up just a PhD in that academic, and I'm so very honored to be a part of, like same event with you guys. And the separate patients connection between the experience that they addicted to and their perceivable response, a neural that are supported in threesome together. And if VR is rewinding the brain, it can cause the human behavior to change their thought and their feeling. So even one of the researchers connect escapism definition with the Maslow hierarchy of needs. I think everyone knows that. It's a pyramid that is defining many types of the human needs, which levels of love and a sense of belonging after the basic psychological and safety needs is mean that the technology help us to fulfill the physical needs and safety needs at the same time. So another researcher core have discovered that how VR or the virtual may only intensify the problem. We have futures application also include the possibility to attach the people in the real world surrounding us. Yep. Another two researchers, Bartkovich and Balancins, they mentioned that technology helped the human escape from the real world, and the internet and the virtual reality easily satisfy such that kind of need. Like people love to be hanging out and being in the group as a social, and drive sometimes to satisfying the addicted user that withdraw from the physical, from the society perhaps, because they're more enjoyable in that particular virtual world and don't want to get into the real world. So another researcher, Kim, declared that virtual reality immersive abilities are so massive. So VR is capable to change the human social and emotional needs over time. Because when you have a friend, you are avatar, you in the VR, and you patting your friends as avatar, patting each other, say hi. It makes some relationship to be just a real relationship. Even you don't know that who actually are behind that avatar that you met in that virtual world. So it's quite interesting in terms of psychologies. And escapisms in VR in the virtual world, it is only the spatial present. It doesn't real, It can trick your brain to believe in virtual. The significant beneficial of VR technology is also mentioned in the UK charity organization they call Spatial Effect, who developed the applications with VR environment, which offer the video game control to make for the people with the disability. Dr. Duncan, the founder of the Spatial Effect, suggests that VR system can help people with the severe mobility challenge or the people with the paralyzed escape from the world and can move in both virtual and virtual at the same time. You already see in the many movies that the disabled people became another persons in another world. For example, like the movie Avatar, that the actor is a disabled people and then turn into a very warrior in the virtual reality world. Is that simple like that? So the virtual reality really caught the human sense and changed the perceptions of the world. So human normally do it and then indulge in the human escapism can help the harmful impact on the human sense of self and relationship. So VR facilitate user to take on the view of other, for example, like I'm sorry if I'm pronounce it wrong, psychophorestic and the elderly and also the colorblind people that prove to be reduced the prejudice and the increased empathy, understanding and helpful behavior because you put someone in the other people's shoes, so you're going to know what it feel like. The example is this. In the virtual space, user can change their appearance, genders, and age. Like it can let the people do things that they couldn't do in a real world. So in VR, fright people because they're so real, and the user are unable to distinguish the real world and virtual world. But on the other hand, the idea of not being yourself, the user can travel any place they like to go, very fantastic, and it's why the people craving to find a way to pretend to be someone else and review the viewpoints and experience from the other. So this is more than the escaping the reality, but it is about creating the deeper connection. Sorry. So this is some example that I bring it for explain more that why virtual reality can bring the children with disability to be in the front row of the Olympic Games actions with spectator larger banning from like Olympic game in Tokyo. Enthusiasts have come up with some idea that how can they brought a fan into the stage without like they're really not there. So from support from the major company, the student from school called Bakuta that have the physical handicap, they were able to participate in the game via virtual reality and viewing from the dome that set up in their school gym. And the kids were also offered to have a chance to meet athletes through the cameras and play with the mascot and all the robot. Look like that they are special guests over there. And also in the United States, and VR is being used to help the student with learning disability and autism. In US Department of Education is betting on the virtual reality to help students with the high functioning autistics and learning disability in school across the country. And this month, the month that I'm taking this paper, the Office of the Special Education is a program and now a lot of investment toward the new program that help the student with the VR to nurture their social skill with disability, and that's also in more and more projects about that. So next. This is also the other project that I found that is involved with virtual reality and disability and patients that this is you can go through this the website. So just give you some of the example. So come to the conclusion. Thank you very much for listening to me. And one of the fastest growing industrial in the world for sure we are. And this high demand create high market intensity among the game player and require specialized operation in order to improve the development, but a little bit be careful of the effect of because while you using it, and it can benefit for the teen and special needs and handicapped children if you try to do it. Thank you very much. I'd like to step.
Thank you very much for your presentation. Спасибо большое. Мы приглашаем.
Thank you very much for your presentation. And now we're going to invite the next speaker. It is Trudy Havermans from Belgium, from the Hospital of Leuven, and the name is Children with Cystic Fibrosis and Their Families, the Role of the Psychologist in Long-Term Care.
Thank you very much. I'm afraid I'm going to give you a completely different sort of talk, the one I've just listened to, because, well, my talk is going to be from the clinic. But maybe that is a nice variation on the theme. I'm Trudy Havermans. I'm a clinical health psychologist, a doctor in psychology, and I work at the University Hospital in Leuven, which is a large hospital, and we've got a rather large clinic with people with cystic fibrosis, about 100 children, 160 adults, and more than 120 transplanted patients with cystic fibrosis. And together with my colleague Janne, I try to take care of the psychosocial, psychological part of our treatment. And today I was asked to talk about the role of the psychologist in the clinic, and as within the theme of your conference, I will focus a little bit on education as well. I'm a consultant of a CF Care educational program paid by Vertex. So what I'm going to do is give you a short introduction into cystic fibrosis, because I'm not sure that everybody knows what this illness is and what it's about the treatment. I'll briefly talk about the importance of holistic treatment, the role of the CF psychologist, as I said, the impact of CF during childhood years and all the developmental stages, and then education, as I see, is one of the ways we could go ahead. And of course, the previous speaker talked about electronic and virtual devices, which is definitely something that we are using in the clinic, for example, in the outpatient clinic to help with procedures. So there was a lot going on, as you said before, and I'll talk to you a little bit about the education in cystic fibrosis. So CF is a rare genetic disease. It's life-limiting at the moment. There's no cure and has a great impact on quality of life. As you can see here, it is multi-organ, with the most important affected organs are the lungs and the pancreas and the intestines. So there is a lot of treatment needed for cystic fibrosis, which is very time consuming. So for example, all patients, the minimum is they would have to take pancreatic enzymes, vitamins, do daily physiotherapy. Many of them do twice daily, and daily or twice daily nebulizing therapy. Often they are on oral antibiotics. Many patients need regular IV antibiotics, which is 14 days in the hospital. Many patients take liver enzyme. From the age of 12, 13, the chances of getting CF-related diabetes increase. So there's about 40% of our patients have CF-related diabetes. And on the long term, without still having curative medication available, many of our patients are being transplanted. So this means for children, this is about 1.5 hours a day of treatment. And for some of our adults, this would take 4-5 hours. Luckily, there's some new medicine on the horizon, but there is very important reimbursement issues. Is very, very expensive, and many countries cannot afford this. And the other thing is that because it's a genetic disease and the medication are tailored towards specific genes. Not all patients at the moment are eligible for this new medication, but there is a promising light in the future, so I'm very thankful for that. Now, what defines a patient? I think it's always interesting to look at it like that. So you've got the patient, you've got his or her family, and you've got the hospital team. But surrounding that, there's very important things that we have to take into account. For example, what society we're living in, what kind of healthcare this patient can use, the cognitive abilities, the educational systems, of course, also the individual characteristics of a patient, the specific disease characteristic, and his or her social skills. And then we can even define this more as what kind of community, the religious background, financial situation, living circumstances in countries that's very different. Wait a minute. Then there is school, society, work. Is there special educational needs? A person's personality, character, resilience, especially if we look at therapy adherence, these are important things. Does a person have an optimistic or a pessimistic look on life? And of course, socially, a relationship, familial backgrounds, parenting skills that we see in the early days are very important, and parental mental health. I'm just naming some of the important things in what defines a patient. And we should never forget a patient can have good luck or a patient can have bad luck. It's not all about what we do, what we have, but sometimes we just are unlucky or lucky. So what's holistic treatment in my view, and I'm sharing this with many other people, is addressing the whole person, including their physical, mental, cognitive, educational, emotional health, taking into account social consideration. So this is a really broad way of looking at being able healthcare and holistic treatment. It's achieving optimal health by gaining balance in all these different parts of life, and a multidisciplinary team. That's probably the best way to address an individual as a whole person, preferably not to see him as a sick person, because this person, even though he's got an illness, he's so much more. So in our team, I'm just briefly showing you this fun picture of, one of the patient association was selling socks. So we were helping them to promote this. As you can see, there's many, many people involved in a multidisciplinary team. And it's, we are lucky to have this. And I know in Moscow, some CF centers in Russia also have multidisciplinary teams. And I think we should be very pleased and happy to have that. So what does the psychologist in the CF team do? We do a lot. It's very difficult to tell you in one slide. Counseling patient and family, psychotherapy, of course. We kind of safeguard the developmental tasks. We kind of focus that when we have team discussion, and we inspire people in the team to have some flexibility with regard to age, developmental level, illness severity. So it's a very important task we have. What we also do since about 5 years is, or 10 years, mental health screening, which has been advised by the international community. So themes that we look at: education, coping, treatment adherence, of course. We focus on emotion regulation or anxiety and depression. And of course, many of our patients have from very early age on have had post-traumatic experience. So we see a lot of post-traumatic symptoms. We focus on relationships, on the impact of CF on school and work, and we help patients to create and to dare to make some sort of future perspective, which is very important. Of course, it's still a life-limiting disease, as I said before. So end-of-life counseling, grief and bereavement are also part of our roles. As we work in a team, the psychologist is often also the person to kind of make sure that there is a cohesion within the team, or if individual team members have problems, because we work with a population that has often very sad stories, we can have a role there as well, also in mediating with families and patients. So if we look at the impact on cystic fibrosis over the development, which I thought would be interesting for your conference, if we start at the very beginning, from infant to toddler, what are the normal life expectant developmental stages, developmental skills that we would expect from a little baby, from a toddler. Of course, the first things that happen in life is to form an attachment, to get some trust in society, in his or her environment, to get some early, basic, very important interaction, and for a baby or a toddler to get to know the world. If you have the diagnosis, which is in 90% done in the first year of life, there is the diagnosis either by newborn screening, or if there is no newborn screening because of symptoms, people have to start treatment. There is often hospitalization. There is a whole team entering a person's life. A family is all of the sudden confronted with many people who all have a little say about their child, and this may have an impact on parenting and parents' mental health. What we see is, of course, initial sadness, guilt, desperation, anger, all sorts of emotions that we see in parents, and this can have an impact on their parenting. I'm just giving you an example. Eating is very important because of the problems in digestion, and we sometimes see an obsession with parents with eating or mealtime behavioral problems. Overprotection we see a lot as well. And on the other hand, if there is very few symptoms, then we can see that parents sometimes don't do the treatment as ideally done, so lower adherence. Parental anxiety and depression can also be a threat to attachment. And important in this time is provide proper education and information, help them integrate the severe illness in the family and involve siblings. But most of all, give them time, plenty of time to come to terms with this very, very important and serious illness. So what do we see with parents? We have to focus on the story of the diagnosis, of their context, also their own experiences with illness altogether. Maybe they've never been ill, maybe they've had illness themselves or in the family. So how do they cope with illness? Education about cystic fibrosis, the use of hope, reconstruction of future. That's why we help patients and families identify coping skills, and maybe there help them to promote and to develop new or better fitting coping styles. And of course, if necessary, we will refer them to people with who in their neighborhood, because people often live far away, and to help them from that. If we then look at the toddler to preschooler, what are the tasks there is, of course, different sleeping patterns. Language is a very important development during these years, and play. And of course, if we play, we learn to socialize, and we learn that there is certain rules in life. So the early rules. Now, we all know if we have 2 or 3-year-olds in our family, they are very often very stubborn, and they don't really want to stick to the rules, and we sometimes call them the terrible twos. In cystic fibrosis, of course, this may cause some problems. This, no, I do not want it, in treatment or in blood taking or in taking pills. And as the previous speaker, we sometimes use this kind of distraction to help children, for example, with blood taking. In CF, of course, in this age, all through school age, parents are responsible, and they need to help children to do their treatment, even though it's not always difficult. A threat could be insecure child raising, projection of parents of their own fear, isolation of the patient from other children because of fear of infection, and strict hygiene rules. We sometimes see this, not very often, luckily, but we do see it, and education here is very important. So the next stage would be primary school. What do they do? More and more learning. Again, sitting still, knowing at school you can't do what you want, but there's also free play. Again, play with rules and social skills. You learn how to take into account the wish and the will of other people, and more independence also from the family. With CF, we see a more of awareness of being different. And again, as here you see, age appropriate information about cystic fibrosis, adapted to the development and to the cognitive abilities of a child is important. We see more and more self-care. We see children who want to do things themselves, and we hope and try to install routine to treatment adherence. We often go to schools to inform schools and teachers and other children about this illness. And as you see here, a nice slide about that. It's very important to interact with the home school, because we've got a hospital school, but the home school is the place where the child is, and the illness is there as well, so it has to be incorporated. So in the clinic, as I said, it's very important to focus on the child and not just talk to the parent, but involve the child. And again, holistically, a child with CF is more than a patient, it's a whole person. And then we come to the next stage, which is often mostly dreaded within the clinic, and that's the adolescent. A changing person, changing physique, fun, rebellion, as you can see here. I don't know whether you know anything about Belgian beer, but this is what patients would put on their statute of their antibiotic treatment. This is a palm and a duvel, and they would go around the hospital like that. It's a joke, of course, but it's fun. But it's also the stage of rebellion, as you know. Social support from friends are very important. Adolescence, normal adolescence development, identity, body image, friendship, sexuality, and of course contraception. But of course, this is also the age of experimenting. And here, for healthy children, this is not a very good idea, but especially not for children with cystic fibrosis. These children have a different time perspective from us, from adults, and they focus on school and their future, but really looking 10 or 15 years ahead. This is really not, their brains are not geared up to that yet. So CF often means they're feeling different and they're feeling abnormal. This may cause to rebellious and defiant behavior, sometimes to aggression, anxiety and depression, or pretending, I'm fine, I don't want to talk about it. At school, we have the issue of disclosure. Are you going to tell your friends at school whether that you got cystic fibrosis or not? And this is also an age where we see new diagnoses, for example, CF-related diabetes, as I said in the beginning. This often is also the start of deterioration. We don't know really why yet, but during adolescence, often we see young people cystic fibrosis deteriorate. Adherence, self-management, self-care are still crucial, but with a person who's trying to break free and who's trying to get some sort of independence, this is very often a challenge. People with cystic fibrosis are not allowed to see one another because of segregation, because of the cross-infection. So luckily we have Facebook, internet, texting, etc., so they can still contact one another. And in this adolescent, we also see the first step to adult care. Now, I'm happy to say we have adolescents who have real problems with all these things, but many, many of them also cope very well. The next step then is the transition to the adult clinic. And here you see a nice brochure, because we've got this program for transition to adult clinic that we have developed over the years. And now I come to my final part of my talk. I hope I'm not extending my time. I'm sorry. Because we think education about cystic fibrosis and living and treatment and coping with cystic fibrosis education, well, it really starts from diagnosis. You can't really put an age to it. Transition to adult care starts at diagnosis, really. So we've been thinking about it a lot. And so we've developed a program with our whole team. It's definitely not only my talk. So we have a program specifically at education at the age of 6 years. Why did we choose that? Because that's when they go to primary school. So that was easy. All the children who are first class of primary school get this program from a dietitian, from a physiotherapist, from the doctor, from the psychologist, the social worker, etc., etc. And this is very geared to their age. We repeat this at 12, of course, with new content. Then we start a transition program at 16 years of age. We've got a specialist coordinator, the nurse and the social worker and then there's a whole lot of information, and also to the parents, because they need to cope with their child growing up, becoming an adult, and there has to be some differences in who communicates with the child. We have an evaluation after 1 year of the transition, which is important. We continuously talk to our patients what they need. Update and education, we provide two monthly newsletters to all our patients. And of course, there is an education program towards transplantation if this is a necessity. And sadly, we also need, but this is part of our hospital life, we have an education program about advanced care planning. This is palliative care, palliative sedation, and as is legal in Belgium, the different systems and regulations about euthanasia. So education and care to parents, siblings, but also grandparents, school, and any other interested party. And it's important to remember, this is my message to you, we need to adapt it to development and cognitive stage, holistic, not just informational. We have to repeat again and again and again. It's everyone's responsibility of the whole team, but without a coordinator, this, you lose track. So it's very important to have a coordinator. Thank you very much. I hope maybe there are some questions. I'm very willing to answer any questions that you may have.
Thank you very much, Trudy, for the presentation and for the insights into cystic fibrosis and your work. Спасибо большое за презентацию. Мы продолжаем двигаться по нашей программе, и я приглашаю следующего спикера. Это доцент факультета коммуникационных искусств.
I'm going to invite the next speaker, docent Natanun Serharoin. The floor is yours.
Thank you very much. Hi. First of all, I would like to thank you, Dr. Tatiana. Yes, and all of us. I'm Natanan Siricharan from Thailand, SCU Thailand. You can call me Dr. Danny. It's easy to remember, Dr. Danny. And today I would like to present my idea about designing a special education curriculum for students with special physical and mental health needs and disabilities. Case study from Thailand. It's very, I think it's very easy. Yeah, because the task of designing a special education curriculum is very important. The Office of the Health Promotion Foundation, or Thai Health, in collaboration with the Department of Physical Education and the Social Innovation Foundation, has designed a physical activity training course for students with special needs for elementary education, and a physical activity teaching guide for students with intellectual disability to promote the health of students with special needs by using physical activity as a medium. The training will enhance teachers' skills in designing physical activities to be suitable for students. Teaching appropriate physical activities to special students will help students to be healthy, along with stimulating the development of students' cognitive skills at the same time. It contributes to increasing equal learning opportunities to be valuable people in society who are able to live happily like normal students. Special students are students with various disabilities in body and mind. Number one, students with visual impairments. Number two, students with hearing impairments. Number three, students with communication disabilities. Number four, students with physical disabilities and mobility challenges. Number five, students with emotional and behavioral disabilities. Number six, students with intellectual disabilities. Number seven, students with learning disability. Number eight, students with autism. And the last one, number nine, students with multiple disabilities. Special education, what does this mean? It refers to the provision of education for individuals with physical, mental, intellectual, emotional, social, communication, and learning disabilities, or who are unable to rely on themselves without a caregiver. The course content focuses on preparation so that students can live their daily lives along with enhancing their academic skills. Trinut Tientong, Minister of Education, said that special education is an important mission of the country, Thailand. The goal is for all people to have good development all around and have good health in all ages. Citizens should have a public mind and should be responsible for society and others. All students as a development priority, and it will require cooperation and collaboration from all sectors. Build a school as a home, build a teacher as a parent, good. Applying modern technology in the change, the Foundation Department of Promotion and Development of the Quality of Life of Persons with Disabilities, Department of Local Administration, Department of Health, and various universities come together right now. It's good story, come together, something like that. To develop special education to meet the needs of modern lifestyles. The important goal of creating a future for all children. Kalaya Soponpanit, Deputy Minister of Education, has revealed that the implementation of the coding for all, yes, you can look from the picture, has seen great progress, even in the face of the challenges posed by COVID-19 pandemic. They have managed to drive policy quickly to accelerate the spread of coding learning, not only for teachers and students, but to spread knowledge to every age group as much as possible. We have a goal to lay the foundation of Thai people to have coding skills so that they can live in the world happily, keep up with changes, and can compete, including teaching the fundamentals of education, reform to our children without boundaries. We will create a body of knowledge and instill coding for people. We can use the education sector to lead and use the mechanism of the Ministry of Education to drive policy continuously with the hope that when learning coding at a higher level, we will be able to build the platform of Thailand by ourselves and eventually be able to sell abroad. Every country can do this like this, not just Thailand. We have a dream. The basis of coding is to break a problem into smaller pieces, think logically, and develop it step by step for our students. Coding is to instruct a computer to do what we want. Coding has many advantages, such as being a skill that helps students develop rational thought, process it in every subject, and to develop things, understand principles, and discover issues better. The problem is misunderstanding on the part of parents of children, with special needs, because they are often viewed as incapable of learning and unfit to attend school with normal student. Most face fear of being teased and fear of being criticized by teachers. So parents did not dare to send their children to school. Co-education of special children or people with special needs needs together with normal children has many advantages as follows. Number one, co-studying create a positive attitude for parents toward children, believing in the child's potential to be developed, overlooking deficiencies in various fields to give special children a chance to show themselves more. Number two, co-education reduces the cost of caring for children with special needs, because there is no need to hire a special teacher to take care of them individually. Number three, co-education empowers children with special abilities, enabling them to better explore their own potential. if the child is interested in a particular activity, the teacher can help foster that interest and provide opportunities to practice so they will continue to develop themselves. Number 4, co-study around the student in the class to learn the differences between individuals and empathize with others. It trains them to be kind, considerate, and ready to help other people. Number 5, co-studying helps to avoid discrimination due to differences or disabilities and enables students to learn to coexist appropriately. Number 6, co-education helps to stimulate life in the larger society, where they are both normal people and people with special needs. Classroom interaction can promote life skills, socializing, and understanding of school rules, enabling the two groups to coexist peacefully. Yes, correct? Number 7, co-education helps to build a better understanding that children with special needs can normally coexist in society. And based on the example of Thailand's case study, I sincerely hope that it will create even more momentum in Russia to make special students and normal students live happily together in society, including parents and families, expanding to communities and societies. They will live each day happily with their own students. It has a positive effect on people all over the world. It is very important to change the attitudes of parents, and all countries must support each other in order to make the atmosphere of learning and teaching techniques in this curriculum for special students become widespread more quickly. And last but not least, something like that, from the experience of working in the Thai public health industry since 1999, about the design of the curriculum for Thai students with gender problems and changes in their physiology and emotion that result in causing social problem, and the campaign for student and adolescent problem of being aware of things that may cause deception for both bodies and property. Therefore, the important point that we want to design learning of students and young people in the heart. Whether it's normal child or special child, we can design courses to respond to the different learning needs of students, as I have presented. But the main thing that all of us working in this field in every country need support is the budget that goes into the action in addition to the government sector. We think that the private sector and people who are ready to come to help support the budget and expenses for all personnel in this mission, because it is a job that requires commitment and sacrifice to take care of the children or grandchildren of every family so that they can grow up with the ability to take care of themselves and work for the family and society, which will make the nation stable and sustainable. Taking care of children is taking care of the world, heal the world, something like that. If there is an opportunity in the future, please welcome to Thailand. Thank you very much. Sawadee krab.
Our thanks to Dr. Danny for his presentation, and we are continue our work. И я приглашаю к микрофону.
I'm going to invite my old friend of the project Учим Знаем, Marianti Papadimitrou. The topic of her discussion is
the topic of her work is working with
children with physical and intellectual disabilities, maintaining channels of communication with society.
Hello, everyone. Can you hear me okay?
Yes, everything is okay. Yeah.
Okay. Thank you so much for inviting me again. And it's such a pleasure to be able to see you, even remotely, in these very difficult times. My wish would be for me to be there, but I'm glad that we're able to connect this way. So let me start with my presentation. I don't know why I can't move to the next slide. Okay. I will be presenting some of the findings of a research that we did in London, in the largest hospital schools in London. And it's about the experiences of the hospital teachers working with pupils with medical and mental health needs. In this presentation, I will just focus on the importance of connectedness and keeping communication channels with the family and especially mainstream schools open. It's interesting that these children, the children with medical needs, are often presented and experience themselves to be invisible. And this is quite true. It seems that there is no record, no official record of the number of children that are absent from school due to serious illness. There is no record of how many pupils receive hospital and home education. And many mainstream schools are not aware of the reason for a child's absence from the school, especially when it comes to mental health needs and psychiatric hospitalization. Now, the real challenge is that even when the schools know, it seems that they don't know how to use this information. And this is mainly due to the lack of training and lack of awareness of what medical needs, how medical needs impact child and education. There are several reasons why this information is really low in this sector. First of all, children with medical and mental health needs are a small size of the pupil population. Sometimes the illness is not visible. They might be absent from mainstream school for a long period of time. So when they go back, schools actually don't, they just want to continue as if nothing happened. But while they're away, most of the times they might forget about them because schools are busy places. And there is also all these issues around stigma and secrecy, especially around mental health needs, because as a society, we're still not open yet to these children. Obviously, the lack of teacher training and experience, the lack of mainstream teacher training and experience doesn't help. And on the other hand, you have overwhelmed parents that for them is very, very difficult to advocate for their children to an education that meets their needs. What the teachers in this study have shared with me is that children, especially with life-threatening, life-limiting conditions like cancer, they become very isolated sometimes. And this is mainly because they might be embarrassed of treatment-related changes, like, for example, hair loss after chemotherapy. So they become withdrawn. And they develop some kind of social anxiety as well. Now, other children, like, for example, the teenagers with cystic fibrosis, as one of the presenters described earlier, or with diabetes, for example, they become isolated, or they don't want to share their information because they don't want to feel different. They want to be treated in exactly the same way as their peers. And sometimes this can be a little bit challenging because they might even refuse to follow the medical treatment regime and follow a healthy lifestyle just because they don't want to be treated differently. Now, with pupils with mental health challenges, the experiences of the teachers working in the London hospital schools was that because of the stigma, hospitalization is usually kept a secret in the family. And returning back to school was reported to be their biggest fear, outstripping any other concern of these children. Their main fear was that they would be bullied and teased if they were to say that they were in a psychiatric unit. And many children might respond to them in using words like psycho or nat. And this is the reason why, as the time of discharge is approaching, they're asking their teachers for a narrative, for a story that would actually cover where they have really been. So they might, for example, use like a story like, oh, I've been to another school, or I've been abroad visiting family, and actually conceal the truth. But what does this mean? It means that they carry a burdensome secret on their own, and they don't have any help when they go back because no one knows. Now, what are the consequences of actually suffering from a chronic illness in terms of the social skills? This is from studies from children with cancer. 42% in one study, that I think it was in Finland, reported having no close friends. And this is compared to the 33% of the control group. Most of them experience bullying. This is from a study from Canada. 48% of these children reported having experienced at least one incidence of bullying. 77% of this was related to their appearance. Informing classmates of the child's illness may increase empathy and decrease the likelihood of victimization, says the literature. And I will give you an example of how this can be done later. In terms of children with mental health challenges, peer relationships have been reported as the most common fear for going back to school. Many children and young people with mental health challenges present with significant anxiety when having to go back to school because of the stigma attached to the mental illness. So they are basically suffering in silence, and they act as if they are invisible. I would like to share with you a story of what secrecy can do and how communication can actually change things and have an impact for these children. This is a story of when I was a young hospital teacher and I was working in Athens. They asked me to go and visit a child who was diagnosed with a brain tumor. The child was in the neurological clinic waiting for his surgery. I remember going there on a Friday, and I met a lovely child, very intelligent, with a great sense of humor. His surgery was on Saturday, I think. And when I went back Monday morning, his bed was empty. I was really scared. I thought that he had passed away, that he didn't make the surgery. And then as I was standing there, the nurse came and said, "Can I help you, please?" And I said, "Yes, I'm looking for George. Where is he? What happened to him?" And she said, "Oh, he's fine. They've just moved him to the oncology unit because now he has to do some radio treatment." I said, "Thank God." So I went there He had the same good feeling, like he was spirit. He was smiling. He was actually very happy to see me again. And I remember it was Mother's Day, and he asked me for a favor. He asked me if he could write a card to his mother. And I said, yes, what a brilliant idea. Let's do that. So I gave him some color card paper and some color pens and a pencil. And he started writing to his mom, only to realize that the skill he has been working all his life, he was year 6, wasn't there anymore. He lost his ability to write. He became so upset that he started screaming and yelling and crying, and he threw away all his pens and pencils and papers on the floor. I became so distressed that I left. Actually, I said goodbye. I said, I can see that you're very distressed. Maybe I can come back tomorrow. And I left the room. At the moment I realized, I said to myself, what are you doing? You have to go back. You have to find a way to help this child. So I went back. I had with me a medical note, a letter from my own doctor. And I said to him, can you please read this? And he said, no. What kind of handwriting is this? And I said, yes, exactly. And this person is a medical doctor. You know, handwriting is not everything. You still know how to read and write. The problem is that your brain cannot coordinate at this moment of time your hand to write. But there are other ways to write. Would you like me to bring a laptop and try if you can write there? And he said, yes. And this is what I did. So I went back with a laptop, and this is the letter that he wrote to his mom. Mommy, thank you so much for helping me now that I'm in bed and unwell, and I'm really sorry for putting you into such a trouble. I love you so much. Don't forget, we feed the wolf of power. And I asked him, what is the wolf of power? And he said to me that this comes from an Indian story. There are 2 wolves inside of us. One is anger, sorrow, regret, self-pity. And the other one is love, is courage, is looking at not giving up, having a bright future. And these wolves are fighting with each other within us. And you know who wins? The one that we feed. So I'm feeding the wolf of power, he said. And then I got in touch with his teacher to see what we can do, because he was feeling really lonely. And these lovely drawings were posted to the hospital with lovely messages like, we miss you so much. We would like you to come back. Now look at these pictures. It's like from a bitter battlefield. It's like from a war. Someone is fighting to win something, as these children are fighting for their health. And look at this one, because I'll come back to this one. Notice the archman. And then I said, would you like to write a letter to your classmates? And he said, yes. And he said, hi, all. First of all, thank you for the drawings and the present. I like them both very much. Guys, don't worry. I think about you all the time. If you could, send me a letter, because I would like to know all about you. I hope everything is well at school, and I really look forward to seeing you again. And then I said, would you like to add a clip art to your letter? And from all the clip arts he could have added, formula drivers, superheroes, he chose a target. And I asked him, why did you choose a target? And he said, well, I chose a target because I do have a target. I have a target to finish with all this situation and go back to school. And I'm going back to this drawing and the archman again, This was one of his classmates. Now see how communication with school triggered a different way of thinking about his situation. What do you see here? This is George's drawing. It's exactly the same archman. This is where he got the idea of the target from his classmate. And he actually wrote, you can see his handwriting. This is after a month when he was able to start writing again using only capital letters. He said, I have a target as well. I have a target, and my target is to come back to you. And the letter came, and the letter read, Dear George, we were very sad to find out that you are in Athens for medical tests. This child comes from the Greek island. We were a bit concerned, but Miss Anna told us it's nothing to worry about. And I underline that, nothing to worry about. It's nothing to worry about, but we're talking about a brain tumor. Are you okay? What am I asking since I'm sending you this letter? Anyway, I hope that you will come back soon at school because we're looking forward to seeing you again soon. We miss you dearly. And the question is now, so this is a child that not only had a brain tumor that we don't know if it's going to grow back, it's a brain tumor that has affected who he is. And he's lost a major ability. He's a straight A student. He was an excellent student. He lost his ability to write. And we don't know what else is going to happen. But then we leave this child to go back carrying this secret that is nothing much. He went to Athens, maybe to have some blood tests. And the question is this what we should be doing as hospital teachers? And how can we link with mainstream schools to keep the connection, the communication channels open? And why is this important? In supporting connectedness, there are two main processes. One is to keep in touch during hospitalization, and the other is to prepare the class for the child's return. We've seen from research that when you keep in touch during hospitalization, it increases the sense of belonging, supports the development of social skills, and reduces the appearance of psychosocial side effects like depression and social anxiety. How do we do this though? First of all, we need to discuss with the family about how much information they would like to share and with whom. Build bridges with the mainstream school as early as possible and keep the family in the loop. Include mainstream teachers in the care of the child. So keep them in the loop. Ask them to keep the communication open and to take care of the child's learning somehow. And also use a range of communication approaches, some more conventional like letters, gifts, even a hospital visit when this will be possible again from the teacher or maybe some of his peers. We've seen that helps quite a lot. And use other ways like FaceTime telerobots to zoom in to important events. The most important also thing is to have the child adjust their appearance depending on the circumstances so that they look nice and good about their appearance. But before, always prepare the class about what they're about to see, about the changes in appearance so that they don't have a physical reaction on the time of the meeting. And also be prepared to support the child emotionally for missing out on celebrations. If they start, for example, crying that they are not there, you have to be prepared to tell them what they will be expecting and to say that it's okay if you feel sad, that we're hoping you will be back soon. And you see here now at Great Street Ormond Hospital School, in Westminster Hospital School, they're using FaceTime to link pupils that are in isolation wards. So they start building up social skills there. If a child is in isolation ward, This is another example of a child, again with cancer, that is linking to the mainstream classroom. The use of telerobots, as you see, one-way streaming. You can't see the child here. This provides opportunity to see the child as well. But as I said, if you choose this option, you have to prepare the class for what they will see. And when it's time to go back to school, and this is my last slide, the hospital schools, we found in the study that it is very helpful if the hospital school gets in touch with the school and actually visits the mainstream class. And I know that this doesn't usually happen because we don't have the time. But this is a practice that we need to develop. And when we go back in a consultancy role with the child to help raise awareness and empathy of how the illness impacts the child. So you see here from Cancer Ed, an initiative where a hospital teacher is going to the mainstream class to help the other children in the class understand what the impact of the illness is, what the illness is, for example, first of all, and how this impacts the child. Why has the child lost their hair? How does chemotherapy and other therapies help them, make them feel? How this will impact the relationships and how they are in the classroom. And this way, we know from all the research so far that if we do that, we increase the likelihood of having social support, empathy, and minimize bullying and teasing in the classroom. In this final slide, I have uploaded some links and you can have a look. What the hospitals, what the teachers in my study have done, and these are examples of other projects as well. They have developed video diaries and photograph diaries to send to the school before the child goes back or when the child goes back, and they project these videos to the class and to the school, whoever the child wants to. We always have to ask the child and the parents, with whom do they want to share this information? And they explain what the child has been doing in the hospital and how they can help when the child goes back to school. And this is very important when you have children on dialysis or children that go very back often to the hospital, because it is very usual, especially in secondary schools, for other children to say, oh, you're just playing through it. Oh, you're just escaping school one more. Thank you so much for listening. It's been a pleasure being invited.
Thank you very much, Marianti, and thank you for this important information on school reintegration. That is what we need very much. Мы продолжаем сейчас, поблагодарили Marianti.
We are going to keep going. We just thanked Marianti. Now we invite Marina Milkumova, Adolescent Health Program Coordinator of the Arab Care Medical Center Institute for Child and Adolescent Health from the city of Yerevan, Armenia. And the topic of our discussion will be social determinants, risk and protective factors in adolescent health. The floor is yours, Marina. Good day, dear colleagues. I'm very glad to see all of you. Thank you for inviting me. This is a very interesting topic. I'll try to be short and keep it within 15 minutes. They're working out some technical difficulties about sharing the screen at the moment. Still working out the screen sharing.
Сейчас мы попробуем, тогда будем переключать слайды. Мы просим техническую службу
Все, вот получилось уже. Видно?
Can you see the presentation right now? Yes, launch it now. Is it on the screen? It is not on the screen yet. There it is. Yes, it is on the screen now. All right, now I shall start. So, dear colleagues, the topic of my discussion is adolescents with chronic diseases and the social determinants of their health. Why I decided to speak about this in particular, because sadly, the amount of children with chronic disease keeps progressing throughout the whole world. And these are the children we should think about in schools, and we have to think how to integrate well and to help aid them, support them. But before speaking about what happens to these children, there are two definitions I need to point out. First, the particularities of the adolescent age. What happens in the adolescent age, and why do we need to talk about that? Is the process of autonomization in this period where the child depends on their own knowledge and skills, and they don't need really parents. And the idea of a sustainable identity is the constant idea of a person of who they are, how are they different, and how that person is seen by other people. These are very important when we speak about adolescents, when we speak to them, especially when it comes to their chronic disease. This is what they need. This is what's going on in their head. Now, chronic diseases. Chronic diseases are a group of diseases, for example, of infant and adolescent age group, which are quite long-term or even throughout the whole life, which need either extensive treatment or rehabilitation. And the social determinants of health are all of the environment conditions where people live and work, where they develop. This is the social and economic status. It's their work, it's their education, social support, the environment as a whole, and their access to the health system. And how are all these interconnected? Why are we talking about this? Look at this. When we speak about how widespread chronic diseases are, we speak about the fact that asthma, for example, is 8.3% in the USA. Diabetes is 0.2% in Russian Federation, 0.24% in the USA. Cerebral palsy around 0.2% throughout the 8 countries of Europe. Epilepsy is 0.1 to 0.5%. We have a special disease which is called an intermittent. This is the Mediterranean fever. This is in the Armenia region, which is 0.4% of children have this disease, and also many other diseases, also those who require palliative aid. There is also the fact that 10 or 18% of children in the world have certain delays in their development, which can lead to being disabled. There's there is the research of school children when it comes to their health, which is called the HBSC study, which shows a growing number of chronic diseases and also more and more psychosomatic troubles that children have, be it headaches, stomach aches, and many other types of pain. And they have a certain psychic element to them, which is very sad. Why do we always talk about this? Because sadly, these chronic diseases, they affect the physical and pubertant development of these children. We know that children which are often sick, which have chronic diseases, they may have a delay in their growth. They might be of small height or weight, and this affects their self-esteem. Such children, more often than not, are infantile, have low self-esteem, they are depressed, they are anxious, which all can affect their health, be it physical or mental. When it comes to independency, whatever it is, or autonomous nature of adolescence, there's the idea that they do become independent, but then they also dependent on, for example, their medicine, their physiotherapy, and this affects their mental state. And especially the children with risk-inducing diseases, they show risky behavior. They start smoking, they start drinking, maybe even using drugs. They start talking with suboptimal companies of their peers. They try to compensate while saying like, what if I'm sick? I'm like every other kid around here. And this leads to further complications of their health. And more often than not, it's usually the case, risky behavior, one type of risky behavior leads to another type of risky behavior, start taking psychoactive substances. Such children may have 3 or even more bad habits when it comes to their health. This affects their lifestyle. This limits their physical activity. They skip planned events, be it health. For example, if they need to take medicine, they need to visit doctors, they need to pass tests. All of this affects their lifestyle. This is a lifestyle that a normal child should have, but sadly, children with chronic diseases are not able to do that, and this affects their behavior. When it comes to their context with peers, unfortunately, what is very important in this age, it is the communication with peers. And this aspect of their life changes greatly due to a chronic disease, be it one way or another, because some joint activities or joint events are simply not possible for such a child due to, for example, tests or taking medicine. For example, diabetic kids are very vulnerable in that regard because they are kids, they want to eat sweets, but they can't. That's why it is very difficult. It's not always that these children can really understand why can't they go to a football match with their peers, their friends, but overall, most of them have 1 or 2 friends, and that already lightens the load, facilitates the whole process. There are also the questions of sexuality and growing up generally for them, because a chronic disease means that there might be a certain delay in sexual development, whereas their peers develop, they get friends, they fall in love. All of this creates tension, creates anxiety in the child with a chronic disease in this case, because this child wants to be the same. This child wants to fall in love, but simply can't because they're seen as infantile by their peers. This leads again to more tension, more anxiety. There is a certain degree of stigmatization, sadly. What's interesting is that chronic diseases and psychiatric comorbidities are actually intertwined, they correlate in each other. It's very often when a child has a chronic disease, this same child may have some kind of psychiatric problematic, be it depression, anxiety, eating disorders, be it anorexic, for example, and many others. This is very widespread. The same can be said about the risk of self-induced trauma, injuries, and suicide with somatic diseases and somatic and psychic diseases. When we speak about somatic diseases, we see a percentage of 1.21. With somatic and psychic, it's 2.54. Suicidal thoughts are seen in 1.22 with somatic diseases, 2.54 in somatic and psychic. Then suicide attempts 1.24 and 3.48. This leads us to the fact that these diseases, when combined together, lead to a higher degree of self-induced injuries and suicidal thoughts. 52% of adolescents with somatic and psychic diseases tend to self-injure themselves. Here is a table where we can see how often adolescents with chronic diseases tend to show risky behavior. For example, if we see the reference group, comparison group, smoking is 37.1%, then in the chronic conditions group, we see 43.4%. Sometimes it's a little bit slower, sometimes it's a bit lower, and then higher. This risky behavior is very widespread and quite visible in these children. Why is this important? Let me say that there is a certain degree of influence on their education, because children with diseases, they will tend to skip more classes. There'll be a certain degree of, they're not always due to a disease. Sometimes they try to manipulate information, trying to manipulate their disease, and this will have an impact on the child's education, further socialization, and whatnot, and generally on their adult life. Why is it being spoken about right now? Is actually because there's a certain special attention. We should not single out these children, but there should be a small degree of a special approach from the sides of teachers, educators, and overall teaching personnel for these adolescents to feel included, that they should have special psychological support in order for them to overcome all of the problems and the obstacles that they have in their way, be it socialization or anything else. There is also a list of problems in the family. It's obvious because, for example, if a child has cerebral palsy, this will have an effect on professional activity of the parents. There are certain expenses that have to be dealt with. And in every family that has a chronic disease, child will certainly meet a little bit of a crisis. These crisis relationships can happen. Then if this child with a chronic disease has brothers or sisters, there will be a certain degree of the fact that the parents focus more attention on the sick child and leave out their siblings, and this can cause another crisis. I'd like to speak especially about the COVID-19 pandemic, all of this virtual world that our adolescents had to deal with. COVID had a hand in this as well, because it probably impacted children the most, especially children with chronic diseases. Well, because first of all, there was a certain problem of the educational system and the health system. During lockdown, schools were closed off and children didn't contact with their peers. There was this social isolation, no social contacts, and this had a negative impact on their health. There is this dependency on the personal computer, this living the reality, the actual reality, going to virtual reality. Children tended to be happy when they left the lockdown and went to schools. They were happy to see their teachers, because kids actually need this degree of speaking, of just talking to another human being. There's also the problem of violence, of abuse in some families, because people are confined to this small apartment, enclosed environment, because everyone is there and the whole family is there, and that's had an impact on children. Of course, this went to the deterioration of mental health and went on to become non-adherence of all the rules, especially those which are connected to the disease itself. Well, a few of phrases from diabetic adolescents. For example, one says that diabetes is like an adventure of guilt throughout my life. Living with diabetes is like a normal life, but with additional work. I'm always being told that don't try this, don't take it. There's a lot of sugar. I meet guys, but they treat me like my mom does. I want to be treated like every other person, my peers. So this is how adolescents treat their own diseases. I want to be a normal kid, but I can't, says a 16-year-old girl. That's why all these factors which are linked to the patient, or the social and economic factors, factors of public health, factors of parental relationships, educational factors, treatment factors, all of these factors leave an impression on the patient. They have to be taken into account when we try to support and aid these children, how to alleviate their situation, be it at home or in school. That's why this psychosocial support is very important. Thank you very much for your attention. If there are any questions, I'm open to discussions. I'll answer because I have a meeting. Thank you, Marina, for speaking about this report. The data was very pertinent. Thank you very much. No questions so far. And we don't really know if we're going to have a Q&A session. If we get any questions via chat to you, you will answer them in your own time. But thank you very much and goodbye. Good luck in your conference. So next report we're going to discuss.
Next paper will be presented by Ekaterina Zorina. She is
Представляем вам слово, подключайте демонстрацию экрана.
head of psychological and pedagogical support of the Russian Hospital School. I give you the floor.
Ну, прежде всего, хочется
So,
поблагодарить организаторов конференции и всех участников за такую прекрасную
I want
возможность
to thank
рассказать о своем опыте
everyone for this possibility to talk
логопедического сопровождения в
topic,
условиях
and I wanted to
стоматологического стационара
speak about the synergy
о
of
тех направлениях
psychological
работы,
support and
которые
education during children's treatment in
непосредственно
an
при
oncology
организации
hospital,
обучения детей, которые находятся на длительном
the
лечении.
organization
Как
of
уже сегодня
educating
говорилось,
children
ни для кого не
in
секрет, количество детей с серьезными
oncology
хроническими
hospitals.
ревматическими заболеваниями
It's no
с
secret
каждым годом
that
все
the
больше и больше
education
растет.
of
Что же
children
касается
with somatic
психофизиологического
chronic
профиля, то
disease
здесь
progresses
статистика
every
тоже
year, and we have statistics
ну, не сильно отличается. И в
which
первую
does
очередь
not
количество
differ
выявленных случаев рака увеличивается. Ну, медики
a lot
с
from last year's.
причинами
There are
считают, что
the same
улучшилась
number of
ранняя
cases of
диагностика,
cancer,
поэтому
and
сегодня большее количество детей выявляется
let's connect
на
this
ранней
to
стадии заболевания. И,
better
конечно, все эти дети нуждаются в
medical
длительном и
and
серьезном
technical
обучении
support,
и
which can
являются в
diagnose
фокусе
cancer at
опыта
early
длительного
stages.
лечения, потому что мы
And
знаем,
so
что
the topic I'll be
при
talking about,
определенных
since the
условиях, да,
organization
они
of
могут посещать
education of
школы
children
родительства.
in
Часть из этих детей долго будут находиться в медицинских
hospitals,
стационарах, другая часть
majority
будет
of these
наблюдаться в
children
амбулаторном
will be
лечении, будет находиться на домашнем обучении. На
homeschooled.
сегодняшний
Some of
день
them will
работа по
be taught
развитию госпитальной
different
педагогики
disciplines
и
in
наш
hospitals.
проект
And our project
является
is
флагманским, да,
a pioneering
не только в планах
project in this field
развития
and
сети госпитальных школ от Калининграда до
develop
Владивостока,
the
но и
system of
большая работа
hospital schools
проводится
from Kaliningrad to Vladivostok.
Сергеем Шариковым
And
на уровне
Sergei
региональной
Sharikov
и муниципальной власти.
carries out
Ключевые
activities
документы
at
были выпущены методические
governmental and
рекомендации
legal
по
levels.
организации обучения длительно болеющих детей.
There were some
И нужно
documents
сказать, что
accepted on the organization of children in
существует серьезная
oncological
борьба
hospitals,
в
and we
последнее
have
время как раз по
big
вопросам
prospects
регулирования
on
тех сложностей,
regulating
которые возникают
these
при
difficulties which
организации
appear
обучения в период
in
длительного
organization of
Мне сегодня хотелось бы
education
затронуть
during
важную тему, а именно
long-term treatment.
психологическое сопровождение в
I
условиях
wanted to talk
длительного
about
лечения.
psychological
Здесь
support of
мы
children
видим, что
during long-term
именно
treatment,
психологическое сопровождение
because I think that psychological
обучением
support
являются
and
неотъемлемой
education
частью
are
жизни ребенка.
important
Это
parts of
важный
a
аспект
child's life. And this is a very important aspect of
это очень
rehabilitation
важный процесс по
and a
созданию
very important
такого
process
качества жизни,
in
которое бы
creating a
максимально соответствовало
better quality of
тем
life,
обстоятельствам,
which corresponds
несмотря
to
на
the
трудную жизненную
situation
ситуацию.
of a child,
Ну, прежде
despite
всего,
the,
все понимают, что
the
ребенок,
illness.
находясь на длительном
Everyone
лечении,
understands
испытывает
that
серьезные
children
психофизиологические
during
нагрузки.
treatment
Существуют определенные негативные
suffers
последствия
from
химиотерапии,
negative
существует опыт
consequences of psychological pressure of chemicals, of treatment, of physical rehabilitation, as well as psychological. And these children are isolated, they cannot develop their communicative skills, their emotional intellect, and the processes are stopped. Treatment we carry out is connected to some limitations in context, to sterile environment. Children face different problems such as stress, psychological traumas, formation of immature mechanisms of protection, and these factors create the need of psychological support, of involvement, staff to develop emotions, to develop creative skills and independence. Children in hospitals must live their usual life, which is maximum at maximum degree close to their life outside the hospital. So they must be treated by volunteers, students, and other participants of this rehabilitation process. This environment of long-term treatment, when a child is in hospital for more than 21 days, there are a few of them, about 3 to 5%, but they do exist, and it is and very often they are isolated and they are excluded from the education. So we need to see the perspectives and indicate these perspectives for adolescents and children. The service of psychological support develops different educational programs based on the condition of a child, which involve interaction with the family and schools where the child studied, and preparation of the class for the return of the child. Sorry, Katerina, we can't see the slides change. Can you please fix this? Yes, now we see them. Okay. Is it seen now? Is it better? Yes, we see the slide with the title directions. Maybe we can change them automatically. Do you see this? No, we don't see the slides.
Очень жаль, потому что у меня на экране как слайд-шоу. Третья маршрутизация.
I'm very unfortunate because I see the slides change.
Слайд с маршрутизацией, нет? О, спасибо, сейчас включат.
So the title is direction. Okay, thank you. The technical support will open the presentation. So we divide children in hospitals, oncological hospitals, into three groups. First group, children with high physical activity in a stable emotional and psychological state. This group is composed of children of mild or intermediate forms of a disease or disease in remission. Second group, children with limitations. They are more unstable in their emotional state and highly nervous. And the third group, children with severe cases of diseases with high limitations on physical and psychological activities. They undergo more serious treatment, and this imprints the models of the organization of the educational processes. It must be considered in composing the educational program because it is directly connected to the sources of our information, which are the doctors and parents of children. It is highly important to follow the state of a child, and this way we can suppose the way the education flows at the this stage of treatment, and if the condition of a child allows it, we propose them to take some supplementary activities. We ask technical support to change the slide. What are the technology of realization of children in hospitals? It is very important to meet children, to establish contact with them. Usually, psychologists or curators participate at these meetings. We discuss the possibilities the school can provide. We learn about child and learn the information about their needs, their desires in education. Also, we learn about the timetable of the child, the treatment they take, and after this, we form individual educational program. We use the data we collected at our first meeting, and after the first diagnostic of psychologists and defectologists, we have another meeting with the speech specialists. After this, we carry out the educational activities. We learn about the interests of the child, which are the base of an individual educational program. And we can add disciplines according to the interests of the child. Also, we hold psychological and pedagogical consiliums, share opinions, and based on our conclusions, we can change the plan and timetable of a child based on the resources and health condition of the child. Next slide, please. I have already told a bit about our first meeting. This is what goes on the first meeting, how we establish contact and which information we try to find out about the child. So at this point, it is had to diagnose all the difficulties that can appear during the educational process, but we try to estimate the psychological and emotional state of the child and give recommendations to educators on holding the lessons. What are psychological and pedagogical characteristics in the practice of hospital schools? This was a hard work which took us a long time, and it's a serious result of collective work with educators. We pointed out the criterions which seem the most important while teaching children who undergo long-term treatment. I want to say they include not only psychological factors but also social skills, educational skills, learning skills, motivation, and everything that happens to a child, their emotional state, their cognitive state. This is very important factors in education in hospital schools. Thanks to this information, we can, if a child has studied in a usual school, we can, based on it, compose an educational plan to reduce educational pressure on child, because children who undergo treatment have less time to study. So you can see an example of a timetable of a child of 8th grade. There are all the disciplines they studied. They are all here, less hours, but they are still taught. You can see individual program of a child with the supplementary hours, and we can also appoint classes with psychologists, logopedists, and other special needs experts. We also have children who come from specialized schools, from resource classes, who studied under special programs. And it is very important for us to have documents of these children and their diagnosis to base our plan on it. In this case, we hold a consilium and make a diagnosis, diagnostic of psychologists, of defectologists, and speech experts, and together we define the main problems and compose the educational plan and understand if a child needs consultations and extra support during their education, because this group of children is most vulnerable to negative effects on their emotional state, which can aggravate their symptoms. Last year, we started a practice of early consulting by further pedagogists who treat children who lost their hearing or eyesight during treatment. And this organization of sport helps a lot of families. These families addressed to specialized local organizations after leaving the hospital. This was a positive effect on children's health because they learned new ways of communication during their time they spent in hospitals. These kinds of education also helps to develop skills and creative talents and provides children with communication with their peers because we transfer children into group classes as soon as we can. And fortunately, majority of parents understand the importance of such classes. Also, we organize extracurricular activities, and they have a positive psychological and emotional effect on child psychology. We can also consider the personal interests of children. It is very important even during the severe illness to do things you like, and we support all creative impulses of children. And after graduating, all children have their own portfolios. This might not be victories in international Olympiads or marathons, but just participation in different quizzes or such group activities, and we do consider it a progress. Because our children, after leaving the hospital, can show that the time they spent there was not wasted, and they are not different from their peers, and they're still interested in life and are part of the society. This creates an ecological rehabilitation and good support for pupils of hospital schools. Next slide, please. So that's all I wanted to say in my little presentation. And I also wanted to say that there is a lot of work to be done. Hospital pedagogy is evolving, and we can see it. Thank you for your support. Thank you, Svetlana. And I hope that in the future we will have more interesting projects and researchers. Thank you, Ekaterina, for what you do. So I ask our technical support to upload our next paper. This is the report of Paklalita.
Now we're going to listen to Paklalita
PhD in medicine,
and her presentation, Infantile Cerebral Palsy, Diagnostic and Rehabilitation. Paklalita has a PhD in medicine, is Chief Scientific Officer in the Laboratory of Children Hereditary Condition in the National Children's Health Center of the Russian Ministry of Health. And right now we're waiting for the presentation. There are some difficulties concerning the sound. Please stand by. It is now working. Good day, dear colleagues. My name is Lolita Pak. I am head of the Chief Scientific Officer in the Laboratory of Children Hereditary Condition in the National Children Health Center of the Russian Ministry of Health. I would like to show my gratitude for having this opportunity to speak to you and speak about the dangers of the infantile cerebral palsy. I'm going to stop on the ideas of diagnosis and treatment of this condition. Infantile cerebral palsy, according to the widespread definition given by Bach in 2005, is a group of permanent disorders of movement and pose that lead to the limitation of the functional activity, which is a condition resulting from non-progressive disorders of the developing brain of the fetus or the newborn. This is a quite widespread disease, and us practitioners, we meet it quite often. And according to official data in the pediatric population, and according to Batsheva, in Moscow, the spread of cerebral palsy in Moscow constitutes 1.9 children per 1,000. Yet still, dear colleagues, lately there's a large amount of diagnostic errors when under the guise of the ICP we see other diseases, for example, hereditary conditions. Here is a clinic study which was conducted in our institution in the Ministry of Health of the Children, shows that from 350 patients which came to us with ICP, 12% of cases ICP was masking a different condition, which is quite widespread. I'd like to draw your attention to the idea that in 77% of cases, other hereditary conditions were masked by ICP, which means those were mixed forms of ICP. In seeing such a high number of diagnostic errors, we decided to conduct a research in order to find the structure of the ICP. And please, colleagues, pay attention what a wide spectrum, wide range of hereditary diseases we had. Those be chromosome pathology or leukodystrophy, aciduria, mucopolysaccharidosis, syndromal states, mitochondrial encephalopathy, and many other diseases, which are progressive diseases. And in order to define what's the difference between ICP and genetic disorders, we've conducted a comparatory analysis of anamnesis and clinical trials of the spastic cerebral palsy, which is one of the most common in children, mixed forms of ICP, which were masking an actual disease, and hereditary disease in themselves. Here, dear colleagues, you can see the following. When it comes to the Apgar scale, children with hereditary diseases, be it first minute of life or 5, they had 7 or 9 points. With spastic cerebral palsy, these children had quite low marks when it comes to the 1st and 5th minute of their life. Please pay attention that children with other types of ICP, please pay attention that children with ICP take a middle ground between these two. This speaks about the fact that it is the mixed ICP forms require more careful diagnosis and even molecular and genetic studies. When it comes to body mass at birth, patients with hereditary conditions, it was over 2,000 grams. In children with ICP, it was lower than 250. In every case, the ICP started at birth. And please pay attention, the idea that patients with hereditary conditions, the clinical manifestation of that disease, only in 56% of cases was shown since birth, whereas sometimes a year, 2 or 5 years after birth, 18% hereditary conditions actually started showing symptoms, and children with ICP never debuted after a year of life. Then we have the delay in motor functions, atrophy of visual nerves we're seen in patients with spastic cerebral palsy. When it comes to sensorineural hearing impairments, in 25% we're seen in hereditary conditions. And please pay attention, colleagues, that children with mixed ICPs took a middle ground between these two. We've analyzed the course of the disease, and we found out that in more than 77% of cases, the non-stop progression of the disease was seen in patients with hereditary conditions, and never 0% in patients with spastic cerebral palsy. It's very important. The more the child grows while having cerebral palsy, we're prone to seeing the deterioration, but it isn't a progression. This is false. It is tied to the fact that as the child grows and amasses more weight and height, the needs or that the things that are required of the child's brain grow. And that's why the problems, the limited capabilities of this child, they become more and more evident. The loss of the motor or mental skills were never seen in patients with spastic cerebral palsy, whereas in hereditary conditions, it was over 45%. That's basically a half of the patients saw a regression of previously attained skills. We've also analyzed the data of neurovisual diagnosis, giving the MRIs of the cortex, and it showed us that 41% the diffused lesion of white matter showed 41%, whereas a spastic cerebral palsy was none. The ingrained deficits of the development of the brain is almost 14% in those patients with hereditary disease. And basing on this case study, we have underlined the predictors which allow us to find out the course of disease, of the hereditary disease in a child, even if this child came to us with cerebral palsy, and that allows us to have a differential diagnosis, be it loss of attained skills, progressive nature of the disease, visual and hearing impairments, a diffused lesion of white matter of the brain, and of course the medical history, be it Apgar scale or weight of the infant. And that's why we've developed a differential diagnostic algorithm which is used in our institution and in the regions of our country. Why do we need to pay so much attention to the idea of diagnosis? It's quite evident, colleagues, because you and I both know that a proper diagnosis means the success of the therapy, a successful rehabilitation of our patients. It's also the prognosis of the disease. We have many, many different rehabilitation programs, be it methods of non-medicamental therapy, overall physical activities, and physiotherapy, and what are the goals that we have with non-medicamental therapy in children with ICP. First of all, it is the personified approach according to the base level of the child, based on the child's needs and capabilities. all methods of non-medicamental therapy aim to improve the medicamental therapy, the symptomatic treatment of all the other diseases that might crop up in the patient, which lower the quality of life of a patient. Of course, when it comes to surgery, people with ICP are quite prone to having pathologies that can be removed thanks to surgery. And then we also have rehabilitation after the fact. Of course, it's a family, it's an aid to the family of solving psychological problems as family rehabilitation. Our center has a wide range of different tools of therapeutic treatment, which is successfully used in order to cure or treat cerebral palsy, be it wave therapy, be it pain inhibition, the reduction of contractures, activation of regeneration, floating with chromotherapy, which allows us to reduce the pain syndrome, reduce the muscle spasms and contractures, and allows us to diagnose and to analyze the current disabilities that the child has, which is very, very important. Our patients really love the HIVAMAT apparatus, which has a soft pulsing electrostatic field, which has electrostatic massage in it. You can see a range of effects that this has on the patient. And of course, there are heat procedures, be it thanks to paraffin and the like, many other methods, a few of which I have on the slide, be it polarized light, pulses, galotherapy, hydromassage, and the like. It is evident that our center pays a special attention to psychological and educational assistance to patients and both families. We have a center for psychological aid for children. It is Svetlana Lazurenko who conducts work of this center, and they cooperate with us to a great extent when it comes to rehabilitation of patients, giving us a giant approach in helping our patients with psychological problems, rehabilitational problems, and the like. As every defectologist, our educators, our psychologist educators, have a personified approach to each patient. At the diagnosis stage, our educators provide a full diagnosis of the psychological functions as well as the social conditions of development, which is very important when we draft up the rehabilitational program. At the stage of rehabilitation, we form consecutively the programs which will have a certain amount of psychological achievements. We also conduct formation of psychological aid for parents. Then we have this stage of control, where we have a full body examination of the patient. We correct the psychological and pedagogical programs. We see the tendencies of the development of the child, and we choose the educational route. And then, of course, our speech therapists, defectologists, educators, and everyone, they conduct dynamic surveillance of the patient up until 18 years old, where these patients are given off to different clinics, be it online consultations for parents, be it online consultations for specialists, or it be even distanced assistance for the child. I thank you for your attention, and goodbye.
Дорогие коллеги,
Dear colleagues, we have to wrap up our conversation today. I thank all of the participants, and I pass the word to my colleague. Some technical difficulties are going on. Please stand by. Natalia, if you could. I didn't catch that, I'm sorry. I'm very grateful, Svetlana, to the fact that we took part in this conference, in our project, the Uchim Znaем project. I'm very grateful that this project took part of this. I thank all of the reporters that were here today with us. Every single one of you had something very important to our work, something that all of us can use in our work. And this can foster networking between us. It will allow us to work together on these problems. I can say this as a participant of this conference that has listened to all the papers that were presented today. Thank you very much again for granting us this chance, and I hope that we'll have more of this. I thank all of the participants that are still here for taking part in this conference, which is of great importance. And I would like to only say that I hope that we will meet in person. They will be able to see our school in Moscow, our platform. We have the whole range of our services that help children with special needs in education. And you can see how well we've set up, how we keep working in Russian Federation. Today, we are known as the project of Hospital Schools of Russia. We have more than 45. Actually, today we're going to include the 46th school into our project. And so I'm very grateful for you to inviting me to this work, even though it's quite not difficult because I'm just moderating. And I had the opportunity to see the wonderful scientists and researchers from all over the world working on these problems. Thank you very much. I wish you a happy new year. I hope that in the coming year we'll be able to see each other in person, and goodbye. Goodbye, everyone.